May I? Okay. Hi, good morning. If I could have everyone take a seat. Thank you for your patience, and we'll get started here in just 2 minutes. Hi. I know we have a few people still coming in, and so we wanted to give them just a little bit of time, so thank you everybody for your patience. I'm Carissa Schweitzer-Mushik. I'm a counselor here in the immediate office of the Secretary. I have the great honor of supporting the Health Services portfolio, so that includes HRSA, SAMHSA, and then the Great American Recovery. As I had an opportunity to meet a lot of you this morning, I actually then see a lot of faces that I recognize too that didn't get a chance to say hi to, so hi to all of you. I'll catch as many as I can afterwards. It just makes my heart happy to see all of you. Everybody here is excited just because this is the right thing to do. It's the right conversation to have. Everybody believes, and all of you are working really hard to make a difference and to really work towards those evidence-based best practices. We know that some of you, I met a few that spent the night in the airport and a few that flew in really early this morning. So for those of you that braved the weather, thank you very much for doing that. And that also is just a testament to how important it is to have everybody here today. So on behalf of Secretary Kennedy and the entire U.S. Department of Health and Human Services, I welcome you and thank you for joining our National Behavioral Health Quality and Best Practices Voluntary Pledge event. I'm thrilled to say we have over 30 states, 188 different unique organizations here at HHS, and then a lot more attending virtually, and thank you to all of those that are on our live stream, some of those that are also still stuck in an airport. As a person that has spent their career in the healthcare field, I just want to say your engagement in this event is really important to all of us here at HHS. It's rare to have these various industries and organizations together, and we have individuals representing and I wrote it down so I didn't forget, because some of you I didn't know were going to be here, representing insurers, healthcare systems, obviously the professional medical and behavioral health organizations, state associations, industry partners, tech entrepreneurs. It really just is, again, an example of how everybody's working really hard to make a difference and ensure there is access to behavioral health care. This day marks a decisive and significant step for our country. Under the leadership of President Trump and Secretary Kennedy, HHS is taking a bold, decisive action to reform America's food, health, and scientific systems to identify the root causes of chronic disease epidemic and make America healthy again. Behavioral health is an essential part of that mission. Mental illness and the chronic disease of addiction are treatable, and today we pledge our commitment that they deserve the same urgency, coordination, and model of care of any other disease. This work has never been more important, and it is incredible that we all share this cause. Again, to everyone joining us, we want to thank you for your leadership, your commitment to this work, and I look forward to the rest of the program. I've had a little bit of a preview on what the questions are going to be, and we have a lot of exciting panelists for you today. So for all of you also that are committed to sharing your knowledge, we appreciate all of you today. It is now my pleasure to introduce Dr. Tim Westlake. He is currently SAMHSA's Chief of Staff. He will be your Master of Ceremonies today, and he will guide us through the morning. Please welcome Dr. Westlake to the stage. Thank you, sir.
Good morning, everyone. I'd like to echo what Carissa said. It's my pleasure to welcome you here to the U.S. Department of Health and Human Services for the National Behavioral Health Quality Best Practices Voluntary Pledge Event. As Carissa said, I'm Tim Westlake. It's my honor to serve at SAMHSA, and was brought in by President Trump and Secretary Kennedy a few months ago to lead the organization. I spent 30 years in the emergency department, providing care to patients in my community and developing drug and addiction policy at the state level, and I've also been in recovery myself for 29 years. I've been the safety net when care fails and the system breaks down, and sadly sometimes I'm the first and last person that a patient ever sees. It's my passion and my life's work to have an opportunity to shape a national response and improve behavioral health for America all around the country. And today, as Carissa mentioned, you'll hear from Secretary Kennedy. It's a significant leap forward. I'm grateful to guide us through it. We have a packed agenda with a fireside chat, panels, remarks, and a pledge ceremony. So we're just going to get started. Again, I appreciate everyone coming in here from around the country, taking the time and energy and effort to be here. It's my pleasure to introduce our opening speaker, Ms. Catherine Burgum. Ms. Burgum is the White House Senior Advisor for Addiction Recovery and is the co-chair of the Great American Recovery alongside Secretary Kennedy. She has dedicated her life's work to supporting people, families, and communities impacted by addiction. And she continues to inspire us to act with conviction and compassion and help make recovery possible for everyone. Please join me in welcoming Catherine to the stage.
Good morning. So great to see you all here this morning. Today, you're doing something that may seem very simple. You're signing a pledge that's voluntary. It's not a mandate. It's not a regulation. But history has shown that some of the most important movements begin with a simple commitment, a decision to join together around a shared purpose. Today, that purpose is advancing behavioral health care through a commitment to adopt evidence-based clinical care pathways for screening, treatment, referral, and measurement of mental health conditions and the chronic disease of addiction. And that's why today matters. Because lasting change begins when people choose to move in the same direction. Behavioral health touches nearly every family in America. It includes both mental health and the chronic disease of addiction. While these conditions are different, they often intersect, and they deserve the same commitment to quality evidence-based care and long-term wellness. One of the most encouraging things about behavioral health today is that our understanding continues to grow. Science continues to teach us more. Research continues to improve care. And innovation continues to create new possibilities for treatment, recovery, and healing. As our knowledge advances, we have the opportunity to let that knowledge shape how we care for people. Throughout history, every major advance in medicine has happened because we were willing to let the science change our understanding. Today, behavioral health is experiencing that same opportunity. Now, for me, this work is deeply personal. I know mental health challenges and the chronic disease of addiction through my own lived experience. For years, I struggled with addiction to alcohol. Today, I've been in recovery for over 24 years. Thank you. Recovery changed my life. It gave me back my health, my family, my purpose, and created these opportunities I never would have imagined, like serving as First Lady of North Dakota, and now helping to lead President Trump's executive order called the Great American Recovery alongside Secretary Kennedy. Recovery is real. Every day people recover. Families heal, children get their parents back, and communities become stronger. That hope is what inspires Great American Recovery. Great American Recovery focuses specifically on the chronic disease of addiction. And our mission is to help America fully embrace what science tells us, that addiction is a lifelong, chronic, relapsing brain disease. And we need to build a system for this chronic disease with the same medical approach that we do for other chronic diseases like diabetes and heart disease and cancer. Today's pledge strengthens that entire behavioral health system. Great American Recovery advances one essential part of that system to help transform how our nation understands and responds to the chronic disease of addiction. Together, they represent the future that's rooted in evidence, quality, accountability, compassion, and care. So my hope is that years from now, we will look back on this day as one of those moments when leaders came together and helped create a behavioral health system that delivers better outcomes for millions of Americans. Thank you for making this pledge. Thank you. Thank you for your leadership. And thank you for helping to build a healthier America, one person, one family, and one community at a time. Thank you.
Thank you so much, Catherine. You're the champion that America needs, and we appreciate your partnership with HHS and with SAMHSA. Now it's my pleasure to welcome Dr. Mehmet Oz, Administrator of the U.S. Center for Medicare and Medicaid Services, Mr. Patrick Conway, Chief Executive Officer of Optum, and Dr. Clive Fields, the Chair of the Center for Medicaid Service Healthcare Advisory Committee, up to the stage. Dr. Fields will be moderating a panel discussion on the critical importance of national standards. And Dr. Fields, the floor is yours.
Tim, thank you very much. First, a good morning and a thank you to Carissa and to Mrs. Burgum for your words. They are always appreciated and deeply felt. And thank you to all of you who persevered, planes, trains, automobiles, whatever it took to get here today. It sounds like weather was a real challenge for many of you. My name is Clive Fields, and I have this somewhat enviable task of introducing two physicians that require very little introduction. First, Dr. Mehmet Oz and Dr. Patrick Conway. Most of you, and I hate to sound so familiar, but I'm going to call, Dr. Oz sounds like a first name, but Mehmet,
I don't think I can hear you.
Dr. Oz sounds like a first name, Mehmet sounds like a first name, so I hope that you don't mind if I take a little bit of familiarity and refer to you as Mehmet here today, especially in this building. But Mehmet is a cardiovascular surgeon, currently the administrator of CMS, and I would be remiss if I didn't tell Mehmet that I trained at Baylor, and many of my professors would see his current job as a significant step down from his previous work as a CV surgeon. Dr. Conway is a pediatrician who has previously served as Deputy Administrator for Innovation and Quality. He has run CMMI, President of North Carolina Blues, and is currently the CEO of Optum, I believe the largest physician organization in the country. Neither of you physicians come from a behavioral health background, but you're here today really making a commitment just by your presence to the importance of behavioral health. Patrick, at Optum was a first mover in looking at standards and guidelines and as a way to quantify both treatments and outcomes in behavioral health. I would love to hear a little bit about how that journey started and some of the challenges along the way.
Yeah, so first, pleasure to be here. Thanks for having us, Dr. Oz, Dr. Fields. For me, this is personal, as it is for so many Americans. I've experienced the mental and behavioral health system as a person, as a family member, and in both the public and private sector. Actually served in this building in the Bush, Obama, and first Trump administration in different ways. And I'll tell one story. Was with Patrick Kennedy at an event where we committed, I at CMS and at the time many private payers, so some corollaries to this event, to measuring quality back in the day with PHQ-9 for depression and other things, putting that into programs. Committed to the collaborative care model, which at that time was the CMMI model, and how do we scale that nationally. So this has been a journey. For Optum, we have a large benefits and care delivery organization that serves payers, employers, governments across the country. And for us, it's just a pleasure to be here to commit with partners in this room. And we've worked, I'm looking in the audience, with Psych Hub, Kennedy Forum, professional societies, so many of you across this room, to clinical care pathways, to quality, to access, that the mental and behavioral health system has to be like the rest of our system. If this was cancer and you couldn't get access, or you couldn't get quality, or you couldn't be on a clinical care pathway, and you know this well, in the cancer arena, we put that into place decades ago, and we've seen the improved outcomes. We have to do that in mental and behavioral health to deliver whole person care that delivers high quality, evidence-based care to all Americans.
Mehmet, lots of priorities at CMS, but you've made access to behavioral health, especially in rural and underserved communities, a priority. Tell me a little bit about that path and how that work is going.
So surgeons fix things. We're going to trade seats. Your mic's on the wrong side.
There you go. This is a guy who's been on TV a few times.
Give him the water. I tried the Rube Goldberg with mine, but I realized yours is messed up, so it's not going to work. So
There you go.
now it'll work for both of us. All right.
You can tell who's in charge here.
That's right. By the way, Oprah always sat on that side of the stage, which is why all talk show hosts sit there, because the entryway to the stage was over there, and she never liked how her shoes fit. So she didn't want to walk too far. So their entire vision of daytime television will change now. It's based on very subtle things, like most of the big decisions we make. A lot of personalities involved. And Clive, as a good friend, I want to correct one thing you said. You said that as a surgeon, mental health issues, Pat as well, not in the psychiatry business, that mental health issues really aren't our domain. And it turns out that if you don't deal with the psychiatric and emotional issues that your patients face, you can't do any of the things we do. Frankly, I don't think any doctor can practice. And I know that for primary care physicians, that's about 50% of the reason they're there has an underlying emotional nexus. It might be that their diabetes is out of control, which is why they came back, but the reason their diabetes is out of control is because they're so depressed and angry about something else. They're not taking their metformin or their insulin or whatever they're supposed to be taking, and so they begin to slip. In cardiac surgery, if you're in that room, you're scared. And the conversation that we're about to have is one where I'm going to have to at some point describe a mortality risk. There is no heart surgery I'm aware of that doesn't have a mortality risk. And if someone comes by themselves, it's a bad sign. Because in your time of need, you should be with community, you should be with folks. And COVID taught us certainly how the damaging impact of loneliness. The prior Surgeon General felt so strongly about it that quantified it as 15 cigarettes a day, as you're probably all aware of. But the actual human cost is one that is addressable if we intervene. So in my case, I would tell patients if they came by themselves that I needed them to come back again with someone that cares about them enough that we could celebrate together about their survival if they had the surgery. And they'd say, well, I don't have anybody in my life, which is, again, a bad sign. But invariably, there was a doorman, a delivery person, an estranged cousin. Someone was in their life that actually does care about them. And reminding themselves that that's true was an important part of my interaction with them. At CMS, we have, and we're going to talk about some of the pathways that have been crafted, some under Pat's guidance years ago. They're out there. One of the big challenges we have is people don't realize they're out there. Your primary care doctor doesn't have to be the only one who manages you. We have clinical care pathways that actually, just like we have them for diabetes and cancer and other ailments, we have them for emotional challenging. You have to actually have a diagnosis to get access to these. But when people don't know to ask and no one tells them, and it's seen as a side issue, not the main course, the entire system begins to falter. And that's why evidence-based systems that drive quality so that we can have accountable organizations deliver that quality are so important. But even there, we have a problem. I'm just going to say that there's an elephant in the room here. You guys care about this issue. There are a lot of people who just don't have it on the radar. And so if you're not focused on it, you're not going to deal with it. Why is it that the numbers of physicians in accountable care organizations has not increased? It's been stagnant now for years. And the reason is the bottom half of the quality pyramid doesn't do quality well. That's why they're the bottom half of the pyramid, so they don't want to be in these accountable care organizations. So the people who come to these kinds of consortiums and sign the pledge and participate are the folks who already are doing the right things. We have to go beyond the borders that we've crafted around this ecosystem, outside the walled garden, and say, hey guys, it's nice in here, come join us. It's not just a hassle, it's gonna make your life a lot better, it's gonna help your patients more than you can imagine. Come join us.
So you touched on the value of community. And Patrick, how does United or Optum think about engaging a community in the treatment of a whole person, not just in a diabetic educator or not just a cardiovascular rehab center, but how do you think about bringing breaking down the silos that surround behavioral health and addiction in a way that drives the kind of success that Mehmet just referred to?
Yeah, I'd give 2 examples. One, interestingly, tomorrow we'll be announcing a community investment in Tennessee. So we think very purposely about how we invest in partnering communities. I also see Dr. Reeve from the community health centers. How do we partner with entities, providers across communities, investing in social drivers of health, investing in mental health support, investing in prevention. Dr. Oz brought up a great point on the accountable care and how do we move the whole parameter. I mean, our physicians and clinicians are in accountable relationships where they're responsible for quality, experience, total cost of care. When you're in that environment, you know that integrated mental and behavioral health care produces better results. There's strong evidence on this. So you deliver via physicians, via therapists, via psychiatrists, via social workers, via the whole care team. You treat for that whole person as part of the community. We've also got our Chief Medical Officer of Optum Behavioral Health in the audience. As we serve our clients, we talk about the importance of access, integrated care. How do we get access to your employees? If you don't mind, I got to call out 3 things he's announcing because it's awesome. It's rolling out today.
No one can write anything
down.
down.
You can write it down if you want. I'll break. Substance use disorder. They're rolling out right now integrated care pathways for substance use disorder to get people into long-term recovery, to prevent, to treat the whole person over time. These are actually all real stories from our people. Jordan, a person who had struggled with substance use for many years. We wrapped that care around him. He's now employed, he's functioning well, he's with his family doing well. Serious mental illness. Sorry, I promise I'll talk less than you, but this is important. The patient stories are great.
I talk too much.
No, you're a better talker than I, by far. You're like 100 and I'm 2.
Don't feel bad, I'm with you.
Yeah, we're 2s together. You're a 10. Serious mental illness. Avery, had struggled with schizophrenia throughout the lifetime. Get on a long-acting injectable medicine, better adherence, wrap around clinical care pathways, whole person care, investing in community. Once again, getting them into a productive life, them and their family. The last, autism spectrum disorder, which actually has 2 components here. One is early identification, treatment, holistic care, not just ABA. ABA is an important component, and I'll come back to that, but physical therapy, occupational therapy, primary care, the whole spectrum. I grew up, I'm a pediatrician, I still practice, I still see kids in the hospital. I grew up with, a lot of people don't know, with a cousin with autism who never got the care she needed, ended up being institutionalized for 50 years before she died. That is bad for her, it's bad for the family, it's bad for the system. Now, the flip of this is we're also going after fraud, waste, and abuse. You do have providers in autism, a segment that are bad actors, and you have to go after that because you need to have that not in the system, if you will, the bottom of your pyramid, and focused on the high quality. So thanks for letting me call out some of the great work from the team, but it's just an example, once again, through partners, you focus on some of these important areas, and you provide services in mental and behavioral health, just like we would expect of any other part of the health system.
No, I mean, you bring
Where's your leader? Where's your
Dr. Paul.
Stand up. So this is torture him. But thank you for doing that.
Just listening to the innovation inside Optum, it makes me think. I mean, Mehmet, you run a huge public agency. Patrick, you run a huge private organization. But innovation doesn't come from just small, nimble companies in the Silicon Valley. It's actually coming from large organizations like the ones that you run. Is there anything that you could share as to how you succeed in actually successful innovation in companies and organizations as large as the ones that you lead?
I'll start with the Rural Health Transformation Fund, because one of the things we can do is put our money where our mouth is and begin investing in areas not to pay the bills, but to actually transform the system, to right-size the system, which doesn't mean smaller. So it's got to be bigger in some areas, often in mental health care, and smaller in other areas because we're not delivering value. So when the Congress and the President, and this was a vision that they had and they wanted to put out there, to change how 60 million Americans see their health care. 60 million Americans, rural America, who have a life expectancy that is years behind that of urban America. And if you look at all the places where they're falling behind, and there are a couple of very clear examples, you can't pass mental health as the leading example. 2/3 of rural counties in America do not have a psychiatrist in the county. 80% don't have adequate quality access to mental health services. So people say, well, put more psychiatrists out there. I mean, how many psychiatrists are in the room? Put your hands up there. It's just hard to get you guys to move to rural America. They're just not happening. It doesn't matter how much we pay for these things. And yes, we have telemedicine and other pathways that we can try to use, and we are funding these programs accordingly. But the real thought behind the Rural Health Transformation Fund is let the governors who know their state and love their state, but they definitely have insights about their states that are different from the ones that we'll ever have in Washington. Let them come up with better ideas. Most of the states came back to us with mental health integrative pathway programs. They have different ways of doing it. We have a lot of states that are now using schools as a nexus for healthcare, which I think is pretty cool. If you go around the country now, most states have vision checks in elementary school. Why do they do that? Why don't they just go to the ophthalmologist? Because no one's taking a second grader, a 7-year-old out of school, going to a optometrist to get examined, and then go later to an eye doc to get the prescription filled, check the prescription. It just takes days out of the life of the kids' at school experience, but also the moms don't have the time. And often these moms are the ones that are having the most challenging effort pulling all the pieces together. So they do that for eyes and eye care, and they do it because it's more efficient. Now we're doing it for kids in school as well, providing more on-campus services to those children. Same thing is also true for the ability of primary care doctors in rural America to now get access to mental health pathways. So access to a psychiatrist and a mental health coach or manager who can coordinate these efforts. So maybe the primary care doctors in your small town, but the mental health manager can get access to a psychiatrist in a larger urban center that can triage a diagnosed illness. It's those kinds of rewiring of the system that help. And I'll give you the last and really good example. If we have world-class expertise like we have in this room, but it's all siloed in the ivory towers of academia, if we can get the grand rounds, for example, to be more inclusive, so smaller centers or clinics can actually participate. Now, all of a sudden, there's an exchange of best practice that's cultural. It's not just intellectual. It's not a test. It's how do you, in practice, deal with this problem? And what's the newfangled idea that might actually work so I can begin to incorporate it in my smaller community? That hub and spoke model is working very effectively. It's working in more traditional approaches to physical medicine. It should work in mental health services, and we're putting a lot of emphasis behind that. And I want to just call out Secretary Kennedy, and I don't know, Ms. Burgum has been a huge leader in this, but the two of them had a great EO that they pushed hard and the president signed to ensure that this was on the nation's agenda. And they've been cheerleaders continuously. And Bobby obviously has had his own personal experience, which he'll speak to when he comes later in this session. But it is the MAHA movement fundamentally is about making it easier to be healthy in America. It has to deal with mental health issues. And Pat, you have been a leader both in this agency, but also when you went into the private sector, taking that same large-scaled approach so that you set a North Star. So a lot of the insurgent companies try to keep up with the incumbents, and they do it by looking at what the incumbents are up to and aiming at the same targets. And it has been a very effective leadership model. Thank you.
Look, I appreciate you saying that. Just, credit to Dr. Oz and Secretary Kennedy for this event. You asked about the public and private sector. I was the longest serving deputy administrator, chief medical officer, and director of the CMS Innovation Center by a wide margin.
Why didn't you leave?
Which shows you, I actually believe in scale and impact in service. It's about that simple. But I will say this, I said this internally one time, it was the hardest job I ever had because it's really challenging every day. So thank you for your service and the teams here. And a credit to you, you're setting the incentives, the outcomes, the expectation, the pledges that you want out of America and all the people in the room, and that's amazing. On the private sector side, to answer your question, we are trying to disrupt ourselves, which is hard as a large organization, but we serve, you talked about rural, and I grew up in a smaller town in Texas. We serve about 90% of rural counties now. We can get a nurse or a nurse practitioner into the home. And then we virtually serve the other 10%. We're doing a lot of work. How to use AI, how to use technology, how to use collaborative care models. How can we reach every American with that access to care? You alluded to it being in all communities. The AI story I tell internally and externally is my first week as an attending at Children's Hospital of Philadelphia, I get a kid who'd gone all around America. This was not mental and behavioral health. Ended up being a rare mitochondrial disorder that he had gone around America for 2 years. And on page 487, figured out the diagnosis of a paper chart. In today's world, using AI, that child should be diagnosed anywhere in America and treated. That child or adult with a mental and behavioral health disorder should be treated. I told you I wasn't going to share the story. It's going to make, I get a little emotional sharing it, but a while back, I had a 14-year-old who I cared for in the hospital. She showed me in a book 100 therapists and psychiatrists, and she had insurance that she tried to get to in the Boston area.
Wow.
She knew she was severely depressed. She knew she needed help. She actually tried to use substances to self-treat. She then went to the top floor of her, which is luckily only a 3-story building, jumped off, had fractured both of her femurs. We've now fixed her legs, and we're looking for appropriate outpatient therapy. That should not happen in America. That child, is somebody's sister's daughter, et cetera. That should not happen. So the work we do together across the public and private sector should prevent people like her from falling through the cracks so they get the care they need earlier and they all get the care they need, which I'm here for.
Yeah, I think for everybody in the room who's directly taking care of patients, whether an ER, an OR, or an exam room, that we've all had exactly that type of experience. And we all want to do something about it. And is that it in technology? Is it in therapeutics? Is it in payment reform? What are you thinking is necessary so that young lady doesn't have a daughter that experiences the exact same thing that she did?
Well, folks don't want to talk about AI very much, but it does start to address some of the concerns that you're raising, Clive. And when Pat said that about the mitochondrial disorder, which, as many of you know, might be the root cause of a lot of the autism, certainly, that we're seeing, it's hard to diagnose it because people don't look for it, and you don't know what you don't know. So one of the beautiful things about technology, if we can use it wisely, and in this room 2 days ago, we had the 1-year anniversary of the digital tech ecosystem that Amy Gleason has crafted. With the President's support and Secretary, he's been continuous. Well, I still have it. I'm still here. I'm not gone yet.
I'm your tech support.
Tech support, Pat.
It's expensive tech support, by the way.
The irony is that when you ask Medicare beneficiaries, where we have a lot of good data, 2/3 really don't trust AI. And for good reasons. I mean, think about it. When was the last time you saw AI as the hero of a movie that you watched, right? AI is almost always the cause of some dystopian, post-apocalyptic world that understandably raises concerns that could happen again, because art predates science, it predates our culture, usually. Artists connect dots that many of us don't see, and even if they're not connected the right way, we tend to see things in that Rorschach test that compel us to believe that's the future. But if I think about healthcare, which is the one exception to that rule, the one place where the average person says, you know what, I could imagine having a really smart coach in my pocket. That maybe AI informed or driven, large language models will be modified so that, if I ask certain questions, I might not get an answer, because that's one of the art forms in medicine, right, Pat? Sometimes parents ask you a question about a kid, and the right answer is not the answer to the question they're asking. A good example, how do I commit suicide? I mean, there's many, many possible ways of answering that, but the most important thing you do is pivot to the question you should be asking. And right now, eventually, the models will answer that question if you keep pestering them enough, because they're designed to answer your questions. But we've seen tools, many of you have witnessed them as well, where that number of times that you might actually get an answer that might help you hurt yourself is under 1%. That begins to approximate what a human would do. And those are the kinds of models we're looking at. We need to have different payment structures for those. They cannot be based on CPT codes. It needs to be based on holistic total cost of care, I think. And if we can build accountable care organizations using these tools to support doctors and nurses taking care of mental health issues, it'll be helpful in ways that are beyond even our imagination right now. But let's be clear about the major limiting factor. It's each of us. I mean, half of our frontal cortex is geared to read the face of the person you're looking at right now. There's a reason we're biologically hardwired to look so carefully to people around us, because we're uber social species. I can tell from subtle little looks in your eyes if you're bored by what I'm saying, if I'm willing to pay attention to it. Sometimes we ignore it. That's a whole separate problem. But if you're actually trying to connect with somebody, that's a remarkable skill set we have. It's hard to scale that. And we've taken the traditional role of family out of this. And I went to actually an event with Patrick Kennedy, that beautiful event they had at the Capitol building, and the question was, how do you scale human connectedness through the healthcare system? And I don't want to ask the healthcare system questions that is not really well designed. You don't want the healthcare system paying your mom to talk to you. That should sort of happen that's part of the deal. She made you. And we're trying to do that, unfortunately, in some ways that I don't have confidence are going to be sustainable. But there might be ways to get you to talk to your mom. And I was just looking at some data from LA County, which is really having a homeless crisis. And just looking at those numbers, example, of 100 homeless people, 10 of them need big time, big ass medical care. Like in a hospital with a professional medicating you probably, or at least dealing with your substance in a very comprehensive way. 90% of the people aren't, though, in that category. And for them, they need other types of social support that might not all have to be within the healthcare system. And we should be thoughtful about ways we can bring other stakeholders into this mix and empowering them to help with those folks. How are you guys doing with this at United Healthcare? Because, many of these folks obviously are your constituents.
Yeah, look, on fixing the system and answering that question, like many large system issues, I think multifactorial. I started work in this building almost 20 years ago. I want us to go faster. But standards and evidence-based clinical care pathways, one of the topics today. Measuring quality, reliably focused on outcomes, and that we improve those outcomes over time. Access standards that are known, measurable, deliverable. And we're doing all these, by the way, at Optum. Tailored clinical programs for the patient. You hit on this too. So you really understand the severity of the disease, the whole person. How do you tailor the program to them, if you will, with the clinical programs, the interventions. Payment, you hit on this as well. Total cost of care, quality experience, value-based care models work. There's although this gets debated in this town now every once in a while, they do work. The evidence is quite strong, just for the record. Definitely better than a fee-for-service system where we're just paying by widget, regardless of the outcome. And you worked on this as well. Mm-hmm. I think those are some of the component parts. We talked about workforce and technology. I'd call those out as well. Then I think the question in front of all of us is, I was in 19 years ago, to be specific, the first time I walked into this building. If you look at our progress for the 19 years, we've made progress due to a lot of the people in this room, but not as fast as we need to, because you still hear those stories. So I think the question and the point of, I think, the pledge and the action is, how do we all take action over the next day, week, month, year to make the whole system better, and that continues. So if we sit here 5 years from now, we look back and say, mental and behavioral health is imagine that, a stellar system where everybody gets access, everybody gets high quality care, everybody gets the care they need, when and where they need it, and that's what we're working to deliver on.
Clive, you've been asking questions. Let me ask you, if you don't mind, because you didn't brag on yourself. Clive has been a real thought leader in primary care in particular. What is the big barrier to primary care doctors wanting to be in some type of relationship with a healthcare manager, or maybe more practically, why doesn't it happen? When someone sits in your office, how many physicians do you have now?
At the peak of the organization, there were 5,500 providers.
Right, so 5,500 docs, and again, conceptually, half of the time they're talking, or at least they're seeing people with mental health issues as a driving factor. They may not be clinically sick enough to require treatment, but that's a major driver. They don't care about something that should be important to them. How do you actually get clinicians in the front lines to deal with that?
It's such a great question, because I can't imagine a primary care physician that wouldn't want the kind of help that a behavioralist could bring to their patients, whether it was an LCDC for substance abuse, whether it was a marital counselor, whether it was a psychologist. The barriers that have been put in place for teamwork exist not just in primary care, but I would suspect all across the healthcare system. When you're in an OR, you have a team. There are 5 or 6 people that are absolutely committed to exactly the same outcome. I can't think, maybe in an ER, as I look at Tim, maybe the team works well there, but I've been in enough ERs, as many of you have, to know that teamwork falls apart in emergency rooms. But where it's most needed is in a primary care office, right at the start of the problem or the identification of the issue. And we look at models like the collaborative care model. We look at all kinds of opportunities where primary care doctors could team with behavioralists to drive a comprehensive, whole person type of healthcare. And I think there's going to be opportunities over the next couple of years of the administration to remove some of the regulatory barriers that stop that from happening, to refocus some of the resources. And it's not about earning more money, it's about getting paid for outcomes. And people talk a lot about value-based care, and I've been trying to use the term outcome-based reimbursement. As far as I can tell, I'm the only person that's using this term. But it makes sense that you should be paid for outcomes, because I always thought that what we did in our exam rooms was valuable, so I kind of thought I always provided valuable care. But I hope so. But as we move towards outcome-based reimbursement, and we do it through the removal of regulations and economic models that actually look at the entire total cost of care, the kinds of models that Optum has really been at the front of, I think those barriers can be removed. The idea of not working in teams now feels so completely just anti-everything that we're trying to do. And that team can include a parent or a teacher or a rabbi or a priest or anybody in the community that can be supportive, as well as a myriad of healthcare professionals working to a common goal.
This all hands on deck approach does work. I'll give you 2 concrete examples. Abe Sutton, who you ran that group too, he basically did everything. Abe is the head of the CMMI group, which is it's like the nuclear reactor of CMS. They come up with a lot of good models and ideas. And he has something called the Elevate MAHA model, which is designed to allow $100 million to go to 30 good ideas, many of them are mental health care ideas, just small little pilot projects to make sure you can put a feather in your cap if you've got a good idea. We have the Access model also from there that allows us for the first time ever to pay for digital tools. And again, I'm not advocating for us to use digital tools to talk to, be your avatar and be your psychiatrist, but at least connect you into the system to navigate for you. And deal with some of the fringe cases that really, and Pat somebody highlighted some of these. And Tim, I shot a show called New York Med, and I told the producers, when you see someone handcuffed to the gurney at dawn, interview them, because something happened that's worth hearing about. And invariably, those stories that got you handcuffed to the gurney at 5 a.m., it arose from some mental health or substance use disorder error you made starting around midnight. And so we have the clues. And I also want to call out the groups that are not, like ARPA-H is doing kick-ass work, looking at large, massive shifts. They're evaluating ibogaine, for example, and other psychedelics and the role they may play. They have freedom to do things that we can't do, for example, at CMS or FDA is not able to do. But I'm being told we have to break for commercial. So if I'm correct, is that right?
I'm going to ask you one more question, then I'm going to break for you.
It says stop, 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 and don't do it, and quit.
One more question.
See, that's what happens when you change seats. I can't see over there.
It says leave. Done.
Go with
How many more do you have like that? Just-
Well, then I'm going to bring this to a close.
Well, I want to hear your
Because
last question.
it looks like stop is winning over here. The pledge opens by promising timely access to high-quality mental health and addiction treatment. And I think that's a goal that all of us can sign up for and recognize the value to our patients, to our communities, and to our own families. And so the commitment that both of you have shown, both in the public sector and in the private sector, is not just commendable, but it should be encouraged, it should be appreciated, it should be recognized, and it's been a real privilege to share these moments with you. So thank you very much.
That's a lot.
Thank you.
Awesome.
Everybody.
Clive Fields for the discussion. I could see that what they were talking about really resonated with the audience and really hit home. And on behalf of HHS, I'm really thankful for their service and the work that they do. For those of you just tuning in, I'm Tim Westlake, just brought in to be the leader of SAMHSA. I'd like to spend a moment underscoring the purpose and significance of why we're here today. And I can summarize this extraordinarily complex issue by stating that we're here to create accountability, consistency, quality, and access. We're here to help millions of Americans struggling with serious mental illness, addiction, or both get on a path to recovery. And we're here to help these people get the right kind of care that they need, when they need it, where they need it, at the time they need it, so that they can rebuild their lives, reconnect with their families, and live meaningfully. In just a short time, all of us will voluntarily pledge our commitment to following evidence-based practices, clinical pathways to ensure that people living with these chronic conditions and diseases can access quality evidence-based care regardless of where they live. Help clinicians coordinate treatment across the continuum of care, and create measurable standards that improve outcome and using science and compassion, most importantly, with the person struggling. This is long overdue, and the responsibility falls upon all of us in this room to do this. No industry alone by itself can accomplish this. Today, two people with addiction or mental illness can receive very different care depending on where they live, what zip code they're in, what treatment program they enter, or what emergency department they end up in. We don't, in many cases, have a roadmap for people struggling with behavioral health and addiction problems to get the highest quality of care and in ways that are meaningful to them. In the 30 years that I was practicing emergency medicine, I saw firsthand the urgency to get people the treatment and the help and the care that they need when they need it. I've seen how these small windows of opportunities, when people come into contact and touch points with the care system, if those aren't in place, what happens? I've seen overdoses. The people, I could not get them medication-assisted treatment. This was before it was commonplace. They would call their family to pick them up, but before that, one gentleman called his dealer, and we found him in the bathroom overdosed. Luckily, he knocked over a coffee machine, or else he would have been dead. Far too often, addiction is not treated as a chronic disease. It's treated as episodic care. Addiction is a chronic illness. Mental health is a chronic illness that needs lifelong treatment. And treatment is effective. Recovery is possible. We just need to come together to create the map of the road to get there. And this can't be done if we continue to be a pill culture, where our attempts to treat addiction and mental health stop with just one encounter, one treatment, one medication. We must change how we provide behavioral health care, transform America from a pill culture into a purpose culture, so we can provide the best possible care to the millions of Americans who need it at the time and the place that they need it. I'm thankful that the emergency services exist because they are the safety net for people when that system has failed. But now we're here together to take historic opportunity to forge a system that works, one with the windows of opportunity opening to care that can be given at the bedside at the time that they need it, and turn fragmented care into coordinated recovery. Many of you are already doing this work. All of us are doing this work. For many of us, this is our life's work that is coming to a head. We separately in our respective fields do this, and we cannot underestimate the tremendous amount of appreciation that we have for the work that everyone's doing. We're here at HHS to bring people together, best minds, the best practices, best solutions, best ideas, break down the silos, get rid of the useless regulatory burden that we see, and make sure that the people that receive the care are receiving the best care regardless of where they live. So again, thank you for being here, for reaffirming your commitment to treating addiction as a chronic disease, and for your willingness to work together using evidence-based practices and for a whole-of-person approach. And also for looking to strengthen the clinical pathways, create those windows of opportunities that we can deliver best care to the patients. I'm going to turn over to the panel for discussions. We have 3 panels today, and I'll be moderating each of them. It's my pleasure to invite up to the panel Dr. Taft Parsons, Chief Psychiatric Officer at CVS and Aetna, Dr. Caroline Carney, CEO of Magellan Behavioral Health, Dr. Shantanu Agarwal, Chief Health Officer of Elevance, and Dr. Catherine Suberlak, Vice President of Behavioral Health Transformation at Humana. Thank you again all for coming up to the panel. Dr. Parsons, Dr. Agwald, Catherine, and Dr. Carney. Thanks for being here today. We're going to get started. We're all here today to renew our commitment to advancing evidence-based practices with high-quality behavioral health services. All too often, the payers and health plans have been seen as gatekeeper to services, and the focus had been, at least what looked to be in barriers and hoops that providers and patients had to navigate to access care, which I don't think is necessarily the truth. But we also know that the payers are incredible partners in innovating care, driving use of evidence-based practices, and improving patient outcomes. I'm going to first open questions up to all of you. We'll do about a minute apiece. The national conversation has traditionally focused on expanding access to behavioral health services. Why is it important to shift now to an emphasis on quality outcomes and accountability? I can start with you, Dr. Parsons.
All right, well, when I saw the seating arrangement, that's when I figured out that I'd be going first. So, you know, one of the things that I think for folks that are knee-deep in behavioral health have known for a very long time is that we just simply have not had enough providers giving care to the folks that need it to really kind of meet the need. I think this is something that hit the general public during the pandemic and shortly after the pandemic. I think a lot more people started to present themselves for care, ask for care, talk about the things that they were struggling with. And that thing that we already knew on the inside became very public very quickly. What we've done since then is really work to figure out how do we get more providers into our own networks to take care of the members that we have. How do we distribute the care better? So a lot of kind of in-office care became telebehavioral health care, and so we were able to kind of reach more rural settings than what we used to reach. But we already know that we simply are not going to have enough people to meet the total need for the population. So we have to be much smarter about how we support folks and meet the needs that they have. But as we've improved access to care to the number of providers, we then started to ask the question, what are we getting folks access to? And the good thing is, you can't judge the quality of care if somebody can't get into care. So getting folks into care is kind of that first step. What we're now doing is really trying to say, now that more folks are getting care, more folks have providers to choose from, more folks who live in far-flung areas that Dr. Oz was talking about that may not have that psychiatrist in their zip code, are able to access care through virtual means. How do we make sure that people are getting actual evidence-based care, that the practitioners that are providing the care are doing what we call measurement-based care, making sure that that actually guides treatment decisions that providers are making. And that's where, that's where we are still kind of in our infancy in behavioral health. We are, I will say, pretty far behind what's being done on the physical health side from that standpoint. And I think that we know that there are best practices out there. There's a good body of research to say what good care looks like, but we don't necessarily have the tools within the system to always measure that and demonstrate that.
Great, yeah, thanks. That's a great perspective, Dr. Parsons. Dr. Carney?
Thank you. I'm not sure if this is on now. Thank you. So I think we have to agree on a few things. First is that mental health care is foundational to being a human. And everything that flows from our mental well-being as a human is essential then to how we build families, how we build societies, how we function in the world. It should not matter as a human with a condition of the chronic disease of addiction or a serious mental illness, what kind of care we get is different by who our payer is. We know what the evidence base is for all of the conditions that we're talking about today. We know what works. We know what individuals should get. So if I am a person who is covered by a Medicaid plan and I have access to services that my private payer would never cover, how can we ever say that we have quality of care across the system that we've developed today that's been very payer-based, that's been based on fee-for-service reimbursement instead of looking holistically, and that has been based, frankly, on fragmentation across the type of provider you might happen to see when that provider picks up your illness, or if that provider has anyone to refer you to. And so as a payer, as a provider, I, like Dr. Conway, still continue to see patients in an FQHC setting. It's incredibly important that we align together to level up what quality is. Quality is more than process metrics. We have for years looked at a 7-day follow-up metric as a measure of quality of care, or whether a PHQ was done, not what the results were, not what happened as a result of that screening, not what happened at the subsequent visits over time, or whether an individual who screened positive actually ever stayed engaged in care. We've looked at what has happened as a unit of care, but not what's happened inside that unit of care. And that's really where we need to align together to get to level up quality. We care about it as payers and as providers because we've seen double-digit increases in costs of care for behavioral health since the pandemic, but we haven't seen markedly lowered rates of suicidality, of depression, of anxiety, of any of the conditions that we're out there treating. So something's going on, and we have to fix it.
Great, thank you. I really appreciate that. Dr. Agarwal?
Yeah, thank you. Can you all hear me?
They'll be bringing the mic up as you.
All right, okay, great. First off, just thank you for the opportunity to be here. This is an incredibly important event, and I'm glad that as a community we are really bringing the focus to behavioral health that is required. I agree with, frankly, so much, of what's already been said. We do have a focus today, sort of in too large a focus on just sort of the process of care that's been occurring in behavioral health. And to some degree, that's understandable, right? I mean, there is a natural evolution that's occurring in this area that's taking us from just getting to a better place of access. And believe me, that journey is far from over. We saw Dr. Oz, or heard Dr. Oz, really talk about some of the data there. That's incredibly important. We are not past the access issue, especially as Americans are sort of thankfully recognizing behavioral health, mental health issues more, and frankly feeling more free with less stigma to come forward. That process I expect to keep continuing, and so access will have to remain an important priority as that process evolves. But to Dr. Carney's point earlier, a lot of our measures today, and measurement is something I deeply care about. I think we all do, because that is the starting point for driving appropriate care, driving value. But measurement today is largely focused, especially in high-stakes accountability programs, on processes, those transitions of care, medication adherence, certain screenings being done, but not really looking beyond that at the outcomes. So maybe I'll just add two things. One is, as we think about outcomes, there's a great value to getting there because it brings behavioral health treatment on par with the rest of the system. We need to get there. It needs to be better integrated with physical health care. It needs to be part of the sort of the daily practice of medicine, and I think there's some real challenges in doing that hopefully we'll have a chance to discuss. But I think outcomes measures align the whole system and aligns clinicians with actual patient needs. And by the way, patient-reported outcomes are a really important part of outcomes in general, and that's, I think, significantly lagging in BH today. The second point I would make is I want to see not just integration between behavioral health and physical health, but that social health component is really, really critical. We did a survey of our members not too long ago and found that there was an incredible overlap between, let's say, food insecurity and depression and anxiety. That is not surprising, right? On the face of it, that is the human condition. When you do not have access to the right social needs, when you do not have access to sufficient coverage, sufficient care, of course it shows up, it emanates as a mental health, as a behavioral health issue. And so part of integration to me is not just that integration with physical health, which definitely needs to be discussed. I think we've made some good progress on. But how do we bring our system of traditional healthcare closer to the social environment and really make sure that it is integrated and that people are experiencing that integration? I think that's how ultimately we will drive improvement in all of these domains together.
Yeah, thank you for that. I think something that really resonates with me on what you said as well is the regulatory burden. You all have mentioned that. And, coming and, from the docs here in the room, we see that. And one of the things that I really one of the reasons I quit my job and came out here to do this is to be able to get rid of that useless regulatory burden. I call it regulatory jujitsu, where we just put in the things that will make the changes, but get rid of all of the rest of the burden. So that's something that if confirmed, I'll look at SAMHSA doing, would be to look at everything that's unnecessarily there that doesn't add to the quality. And I think we should look at that everywhere in medicine. I think the insurance companies, payers should look at that. I think we need to look at that in the hospital systems. We need to look at that at the federal level, at the state level. I think one of the things that we need to do is get rid of the obstacles that get in the way between the patients and the people that are giving them care. And that's what the system should be. And that's the vision I have for American healthcare is providing the tools and services that gets the best care at the bedside. I know we all share that, but I think we really need to focus on that. So, and again, Mrs. Suberlak, you want to?
Yeah. Hi, it's great to be here. First, I'd like to say thank you for elevating me to doctor. What I'll clarify is that I'm a clinical social worker, and I think it's great to represent multidisciplinary individuals up here, particularly piggybacking off of what you talked about the experiences of our members that require whole person care. So agree with so much of what my colleagues have said. What I would add is why quality is important beyond just the access piece is we're very interested in understanding not just are our members being seen, but are they getting better? And what does that look like from a perspective of right care, right time, and in the right place? Meaning, talking about the patient stories we heard earlier today, we want to ensure that we can reduce suffering. So many in this room, I see head nods, you know this, but often an individual who experiences a chronic behavioral health condition, they may suffer for close to 11 years before they are receiving the care required to have recovery. And I think as good stewards of both taking care of our members and the provider experience, we can create a simpler opportunity for both reducing friction, reducing how you access that care, and then overall feel better.
Great, thank you for that perspective. I'm going to kind of jump around a little bit. I think this is an important question. I'm going to start with Dr. Parsons. I'm going to go, if you could advance one policy system or change, if you could kind of wave kind of a magic wand over the next 5 years to improve behavioral health care, what would you do? And why would you do it?
Well, one of the things that we continue to go back to in conversations with the providers that are within our network is, from a behavioral health perspective, one of the things that happened when they brought in meaningful use requirements in the HITECH Act is that behavioral health was kind of left out. And so we have a substantial portion of our provider network in behavioral health that is not using an EMR that meets meaningful use criteria. And what that does, especially when we're trying to look at quality that's a little bit beyond what you can find in a claim that gets submitted for payment. So insurers, we get a large amount of data about a very limited set of things. What comes across in a claim is like, who was the person, who was the provider of care, what setting was it in, what diagnosis was treated, but there's not a lot more that we get. We get that for a lot of people. But we don't really know that beyond that unit of service that was delivered, did that clinician actually use a measurement-based tool to assess the severity of the condition, and was it an appropriate tool for the condition that the person's diagnosed with? We don't have that level of visibility to be able to make a judgment of whether or not that person's getting good evidence-based care. And on the physical health side, the use of meaningful use EMRs has really helped to advance that discussion. It's helped with national quality standards. It's helped with the conversation going into value-based care, and that's something that we don't yet have on the behavioral health side. And so I think that if there is a policy issue to be addressed, it's kind of bringing the behavioral health providers up to speed from an EMR perspective, because that facilitates a lot of these kind of discussions and conversations that we can have about the use of clinical care pathways, about how that changes the manner in which we contract with providers. And so that's a big issue for us.
Yeah, that's a great perspective. Thanks, Dr. Carney?
Mine is a very different answer, and so I'm going to say I would fundamentally blow up the system of care as we have it today and look at a very different model of care. We have a model of care that could work, that we've seen in other parts of healthcare, that should be led by individuals at the highest level of their license. Those today are psychiatrists, and we have dwindling numbers of psychiatrists across the country. And in a team-led model of care, we can see thousands of patients on a psychiatrist's panel instead of hundreds of patients. A psychiatrist at the top of a panel or an equivalent physician can then work with the therapists, the peers, the faith-based organizations in the community, the social connectedness that we need to have in that system of care, and really create a team that gets the diagnosis right from the top, and it trickles down to ensure that the right care pathways are used, the right evidence is used in terms of treatment, and the right reach into the community and into the patient's other needs are being met. Maybe that's a dietitian, maybe that's a worker in the peer space or in the addiction space. But we can set up a model of care where we can really expand the reach of the psychiatrist into a much greater level than it is today. And we see some models like this in the FQHC setting today. I'm going to talk about one that's very near and dear to me, where we created an integrated behavioral health clinic into an FQHC that now has wide reach into the community. Yesterday morning in rounds, just yesterday, a very well-seasoned therapist said to me, Dr. Carney, we have a patient who has depression as a diagnosis and bipolar disorder as a diagnosis. How am I supposed to treat this person? How is it they have both diagnoses? If that's the level of, thinking that a therapist may have because they haven't been trained in the hierarchical use of diagnoses, then we're going to get off on the wrong foot of care almost every single time. We can fix that by creating a different model across every community in this country that will work. And if that model is foundationally where people first come to care, whether it's in primary care or whether it's in specialty medical care, that group, that model can then extend into inpatient care and other levels of care to pull everything together. It is the quarterback of behavioral health care that we could use to ensure that no one falls through the cracks and that we are linking from inpatient to partial to residential to outpatient care in a holistic, patient-centered, integrated way.
Yeah, that's awesome. The ideas that you guys that we've had are just amazing, and I'm so grateful that y'all are here and that we're able to share these. I think that's what we need to really transform the system that we have into what the system could be, not just what it has become. Dr. Agarwal, we'll take a crack at it. What do you think?
Yeah, so again, there's just so much potential between HHS and CMS and other agencies on what can be done to further this field. I think the whole audience knows, right, like the incredible role that you all play in clinical standards, in quality, in payment, in value-based purchasing, in the adoption of technology, to Dr. Parsons' point. All incredible, all very important, and cannot be overestimated. There is one point that I just want to focus on a little bit, which is the education of clinicians and other health professionals. Again, CMS and HHS play a really important role. And Tim, you're an ER doc, right? I'm an ER doc. I would bet that you, like me, feel so much more comfortable treating hypertensive urgency and emergency than depression, than anxiety, than bipolar disorder. That's a problem, right? Especially in a system that continues to have access issues where there are going to be ER docs in every community, but not maybe a psychiatrist in every community. You don't always have the opportunity to be surrounded by behavioral health therapists and experts, like I happen to be here at this table, right? Not everybody has that asset. So how do we make sure that this area, again, the whole point is let us not make it exceptional, let us make it part of the normal standard of care delivery that everyone gets to experience. And in order for that to happen, it needs to be part of the daily education of our clinicians. So again, I think an incredible role that HHS plays. I think it needs to be embedded in all of the, the residency programs and the undergraduate medical education in all of the different clinical fields, so that one day, and I don't think it's happened yet, but when an ER doc graduates from a program, they'll say, yeah, I will go treat that depression or that anxiety patient because I know exactly what I'm doing. I'm as good at that as I am trauma.
That's great. Ms. Suberlek?
The benefit of going last is I get to just build on the ideas that have already been shared. Where I would love to expand on the model of care that Dr. Garney so eloquently said is that I do think it can be bidirectional, and done well can both simplify it for the patient, but then also if we can reduce the administrative burden. So if it is about dynamiting it, which I do like, it offers us then to also build in peer supports or individuals with lived experiences, having it be patient-centered. We've done incredible work as a country over the last several years to reduce stigma, but I think we still have quite a bit where we in this room can identify those that may need care, but are individuals engaging. So they may access it, they may know where to go, but how can we maintain their engagement in high-quality care so then we can see prevention in relapse and prevention in ongoing episodes. So I think both being bidirectional, because I completely agree about the specificity. If we do not get the original treatment and identification right, it can become very complicated. What I would call into that too, it was brought up earlier, but just leveraging digital technologies to also get it right from the start. If we think about that patient case that you brought up that just happened yesterday, I as well have seen patients for over 20 years, west side of Chicago, started in FQHC, so sat through several of those morning huddles, know exactly the scenario that you're talking about, and it's all too common. And it's often because individuals with behavioral health conditions, whether that is mental illness or substance use, present at several different places. And they may have short stays, they may interact with a workforce that maybe has not received the highest quality that we can provide. And so at their next point of care, you may be looking at a host of diagnoses that don't help you in that point of care. And so how can we both identify early, leveraging technologies that are available to us today, looking at that 400-page medical record and getting to it quickly, leverage and optimize the entire workforce from patients with lived experiences all the way up to our highest trained individuals, and go both ways. So there's kind of no wrong door for our members, which then lastly what I would add would just reduce the entire system. Because if we can build what Dr. Carney and the rest of my colleagues have described, it can reduce the burden for those specialists, for those primary care providers we would like them to work to optimal license as well. So then how can we offer our expertise to wrap around that member experience and ensure that they're getting the best care possible?
Great. Thank you guys so much. I really appreciate you all taking the time to come out here. That was, I think, an amazing panel, and I really appreciate your work and your service. Okay, I'd like to introduce our next panel. If we can get the, gotcha. For the next discussion, we're gonna welcome members of the second panel, each representing the national stakeholder organizations. So we've got Chuck Ngolia, President and Chief Executive Officer of the National Council for Mental Wellbeing, Rob Morrison, the Executive Director of the National Association of State and Alcohol Drug Agency Directors, Deb Witchey, the Chief Executive Officer of the Association for Behavioral Health and Wellness, and Dr. Q. Ree, Chief Executive Officer of the National Association of Community Health Centers. Again, I want to thank each of them for their appearance joining us today. They represent the key behavioral health leaders in the state and community levels across the country. Each of them has been working for many years to strengthen the behavioral health care delivery system, to break down the silos and fragmentation in care. And often they've been doing this through a patchwork of funding from federal grants, Medicare and Medicaid, private payers, state and local funds, donated funds, and more recently, opioid settlement dollars. Yet we still always seem to be struggling to maintain and sustain the system. I'm going to open up the questions to y'all, but I'm going to start with Chuck, and we continue to go around. Chuck, from your perspective, what do you think the biggest opportunities are immediately in front of us and then on the horizon to finally realize a comprehensive system of care that provides timely access to quality treatment and support of people with behavioral health conditions?
Well, thank you for the opportunity. So I think CMS and SAMHSA have been leading an incredible effort over the last 2 years through the implementation of certified community behavioral health clinics to try to bring national standards, national data, national expectations. I really resonate with something that was said earlier today, that it shouldn't matter in this country where you live. You should have access to evidence-based care, and that, I think, is a huge opportunity. And I think we have opportunities to continue to improve as a country to make sure that mental health and substance use care is integrated. And I think the emerging research around a transdiagnostic approach, I think, also is very important, not being fixated on a particular diagnosis, but really focusing on what are presenting problems and how do we help people return to their highest level of functioning as quickly as possible, I think, are really great opportunities. And then lastly, I would say we have something to learn from the rest of the world in terms of task sharing. How do we expand the universe of people who can do evidence-based psychosocial interventions beyond clinicians to take some of the pressure off of the shortage of clinical personnel that we have?
Great, thanks, Chuck. And Rob.
Thank you. Thanks for the opportunity as well. Really appreciate your leadership, and congrats on the nomination. I work to represent state alcohol and drug agencies around the country, and I think it's important that we're in convenings like this together with all the different sectors, and I can't continue to talk about that without recognizing Patrick Kennedy, who's been promoting this work across so many sectors for so many years, and I appreciate your leadership. And I also think there's an opportunity that was referenced earlier, and that's workforce, and that's something we've been talking about, all of us on this panel, And I think if folks see early on the work that you're leading here to professionalize, to continue to press on quality and data collection and accountability, quite honestly, I think it'll foster an environment where it'll incentivize people to go into the field as it's seen as a professional field like any other, as it is. Second, I also think there's an opportunity, given Secretary Kennedy's references consistently around wellness, that we talk about prevention in this sphere. In our world, prevention is critical. You can't do prevention without relying on sectors across the entire community. And we know we have to do a better job talking about the people who engage in the work of prevention. That's really important to us, that people know there's something called a certified prevention specialist, that their craft is based on expertise. And I want to recognize SAMHSA's work to promote prevention fellowship program to provide that tier. Also, finally, I want to recognize the work here at CMS to continue to have all sectors at meetings like this. I want to recognize the Association of State Medicaid Directors, Kate McAvoy is here, and the work we've been doing across a lot of different areas, but making substance use disorders a priority. So thank you.
Great. Thank you, Rob. Brian, Dr. Hepburn.
Thank you. It's a nice opportunity to be here and work with you and learn from our peers, and gives us hope. So thank you. I work with the National Association of State Mental Health Program Directors. That means that we work with leaders in all of the states and territories, and we try to help improve mental health access and the quality of services in all of those areas. So about 10 years ago, this will only take a few minutes.
We got the guy with the card up front, though, Brian.
Yeah, I can't see that far. So about 10 years ago, we decided we really need to focus on beyond beds. Services were pretty good at emergency room level and inpatient, but most people didn't need that level of service. So we started emphasizing trying to build in the services in the community to keep people out of higher level services. As a result, we've developed papers. We have about 70 papers on beyond beds. And they were led by Deb Pinels, who is one of the premier psychiatrists in the country and a really good writer. What it did is it helped all the states and territories move towards more emphasis on community treatment. Then came along crisis services, the emphasis on crisis services. Then came 988. So the beyond beds work that we did really played well in terms of states and territories being ready for crisis services and 988. So when you ask me what will make a difference going forward, it's continuing the emphasis on 988, crisis services, CCBHCs. We have a really good model out there. The problem is we're not able to take it to scale yet. With time, we'll be able to take it to scale. With full penetration across all the states and territories, we will have a really good system. And that's what I think will make a difference.
Awesome. Great. Thank you, Dr. Hepburn. And
Thanks. I'm really tempted to build on that, but it's not directly maybe later. Not directly related to the work we're doing at Association for Behavioral Health and Wellness. So you have just heard from the health plan members of ABHW on the first panel, and much of what they talked about is really where our focus is. So it's about the idea that we want people to have access. We want there to be no wrong door. But more importantly, we want to make sure people are getting better. Are they getting functionally better? Are they feeling better? And that really means building on this idea of quality and evidence-based care. And that's what we're all here for today. But how do we build the system that supports that so we're not seeing little pockets of it, but we're really seeing it built throughout the system. And that's what really thrills me about looking around this room today and the people that you've gathered here, is these are all the people who are part of this system. And as I came into this role about 18 months ago, I've sat down with a lot of people in this room and heard from everyone. And what I think is really promising is that everyone has the same destination in mind for the patient, and that's the most important part. The health plans, as you've heard and as Dr. Westlake pointed out, play a bigger role than just paying the claims, and they really can help to guide that process and work with all of the organizations in this room.
Great, thank you, Deb. Dr. Ree?
Thank you so much. It's a real pleasure to be with all of you, and I do reflect on a quote that I often like to reference, Helen Keller's, alone we can do so little, together we can do so much. And so as I reflect on many of the faces here and the opportunities for these three panels to share what we can do together, it's exciting. So there are three things I was just going to highlight. As a primary care doc, as an internist and pediatrician who represents the largest primary care system in the country, community health centers, I want to express definitively that mental health is health. And the importance of our opportunity to work together and think about this system and how we assure mental health is health and how it's valued. And leaders like Patrick Kennedy and so many of the folks in this room are dedicated to that core purpose. I also want to highlight, as a primary care physician who worked here at the corner of 14th and Irving when I started my career nearly 20 years ago, that I recognized that a large percentage of the conditions I was treating, of course I had diabetes, hypertension, but depression, anxiety disorder, broad range of conditions, that it was the responsibility of myself and my team to assure we prevented, screened, detected, and treated. So 70% approximately of behavioral health issues, mental health issues are treated in primary care. And the importance of advancing science and evidence in those settings is really essential. And I'm grateful to be at this table and be in this room to highlight the importance of that. The last point I want to make is the importance of two T's, I think, when we think about this opportunity. It's trust and teams. And so as I reflect on community health centers, we've grown since 1965 to now be the largest primary care system in the country that serves 52 million people, 1 in 7, including 1 in 3 in rural America. We've built trust over those 60 years in over 17,000 locations, including 1 in 4 of those locations are school-based sites, like sites that I was at, like elementary, middle, and high schools. And so that opportunity to think about mental health early and think about prevention, screening, detection, and treatment, I think is really important to do it in a whole person way, family-centered way, community-based way. So that trust is going to be so important as we look at the challenges in mental health. So I want to emphasize that. And then the team. And I loved, coming right out of residency as a National Health Service Corps scholar, the challenges of serving all these issues in a 15-minute primary care visit were significant. But having the team behind me or with me, ultimately the social worker, the psychiatrist, the psychologist, to have that team, the substance abuse counselor, the pharmacist, the dentist. We have many dentists who do mental health screenings at our community health centers. It is so important that that whole team, the community health worker, works together. And so when I think about the opportunity here, it's that important area of trust and teams and how we integrate primary care and mental health and make sure mental health is health.
Great, thank you. Great. I don't want to get too negative here, but what do you think are some of the key issues that hold the communities back and the states back from giving the care that we should be giving? I'll start with Chuck.
Well, I am so excited by your desire to look at regulatory burden and simplify. I think that is probably I see a lot of people's eyes lighting up in the room around that.
All the doctors' eyes are lighting up for sure.
Well, and not just doctors, right? If you think about, Brian mentioned 988, and the ability of everyone in this country to have a 3-digit number to connect with someone in a time of crisis has been incredible. And almost 90% of people who call that number feel like their issues have been resolved because they're able to talk to someone right away. In this country, if you present in the public mental health system, you are promised 2 to 4 hours of assessment and questionnaires, and then you come back in 2 weeks or 3 weeks to maybe see somebody. And we wonder why the modal number of visits in this country is 1. We have got to take that on.
Great, thanks, Thad.
Recently, you released the survey on drug use and health, and I appreciate all the work that went into developing the data around it. And a couple of things jumped out at me that we're still struggling with, and that was citing reasons for not receiving treatment. We're still at an astounding 82% think that they should be able to handle it on their own, that they should iron it out. And that another significant portion said they didn't have time for treatment. And I don't think we're talking about folks who want to spend more time at the gym or at the beach, right? I think we're talking about the basic needs that they have regarding childcare, their job, where they're living, all the data that you've been promoting as core data sets, a place to live, a job, and connections. Those are core challenges that I hope this convening will help jumpstart and continue to increase access, as Chuck referenced. So thank you.
Great, thanks. Thanks, Rob. Dr. Hepburn.
Yeah, thank you. So I'll stay with 988 and crisis services and talk about one of the barriers there is the lack of participation of the private payers. Financial sustainability is a big issue, and the lack of the participation is a problem. So we all need to do a better job of getting the private sector in terms of the private insurers involved in covering crisis services. That's one. 2 is that we need to do a better job of getting law enforcement and the judges involved with the crisis program, because what happens right now is that if law enforcement gets involved, they pick somebody up, the fastest drop-off for an individual, and I'm talking about misdemeanors, the fastest drop-off is arrest and take to jail. So you have all these individuals with mental health problems, substance use problems, don't need to be in jail, but are taken there because the system answer to dealing with them quickly is jail. We need to change that. Now, in some jurisdictions, we are changing that. We've gotten law enforcement involved, and they're dropping people off at crisis programs rather than arresting and taking to jail. Now, why doesn't that happen all the time? Well, one of the problems that you get into is it's a matter of, in some cases it's statute, some cases it's culture, where individuals are picked up and they're not taken to a crisis program because they have to go to the emergency room. Well, they don't make it to the emergency room because the fastest drop-off for that policeman is to take the individual, arrest them, and take them to jail. We need to do a better job of making it clear that you don't have to go to the emergency room first. You don't have to have medical clearance. You can go to the crisis stabilization program. Whatever barriers there are in the state that's contributing to that, we need to change it. A third point I would make is the Institution for Mental Disease. This category was developed in, 1965? And it was to keep the federal government from having to pay for long-term care. At that time, somebody could be in a state hospital for a year. Well, they did not want to be the federal government to pay for that. Well, now we have crisis stabilization programs, average length of stay, 3 to 5 days, that have over 16 individuals that are considered IMDs. What does that mean? Medicaid can't pay for individuals in an IMD unless they are under age 22, over age 65. So we need to do a better job if we're really focusing on the best practice model is 988 and crisis services. We have to remove those barriers in order to take it to fully across the country, full penetration, full scale.
And you bring up a great point, I think, with the justice system, and it kind of reminds me of the things that I'm seeing here, which I think are unique to HHS and to this administration with Secretary Kennedy and President Trump, is wanting to break down the silos. So we're looking to work with Department of Justice on how do we connect people, drug courts, what can we do? And again, this is not just federal stuff. The real work gets done at the state level, at the county level, and that's where y'all's work is so critical in this. And so, we're working with HUD, breaking down the silo to make sure that people get access to treatment and not just housed and by themselves. And so I think there's this unique window of opportunity. I think we all can see that we have this time that we can make some structural changes, and I hope we can take advantage of it.
Thank you.
Yeah. Deb?
And I would concur. I think, and we've heard this throughout the morning, that a big piece of this is the fragmented way that care is delivered. And that certainly is true in physical health, but becoming less so, but certainly in the behavioral health field. And that is because some of those services are delivered by the private sector through the health plans, with providing crisis services and providing prevention and providing other services through the medical model. And then we also have the piece that is being provided more through a public health model, and all of that is not always being linked together in an efficient way. We also don't really have the infrastructure in place in a way that really works well. So we've heard about I think Dr. Parsons raised the issue of interoperability and being able to build that system so that records can flow well and information can flow well. And behavioral health is not a piece of that in a systemic way yet. So that's definitely something that we need to take a look at. I would say the last thing I wanted to mention was just around this issue about workforce, and we've touched on it throughout the morning. And this really is about more than payment. There was a recent article in Health Affairs that looked at some of the workforce issues, and we have shortages in some areas, in some fields. We have geographic distribution issues, which we've talked about. There are some pipeline and training kinds of issues that make it hard to get into certain fields. And a lot of other issues around licensing and administrative burden and those kinds of things. So I think really taking a look at workforce and going back to the T and the teams is something that's critically important if we're really going to have a system to deliver behavioral health services in this country.
Great, thank you, Deb.
So I've had the opportunity in my first 3 years as the CEO of NAC, traveling to 49 states and territories across this country and listening firsthand from frontline clinicians and leaders in these health centers about the challenges that they face. And often those frontline clinicians include primary care, but also a lot of behavioral health folks who are key members of the team. And when I ask them, like a primary care clinician would, like, what do you need, or what is your chief complaint? It's funding and workforce. Those are the top two. And obviously they overlap with each other. So as we look at, and that's what's so great about, bringing the public, the private sector, payers, providers, all of us together to address that challenge, which I think is fundamentally about funding and workforce. Now, what's the solution to consider this? I'm going to go to the framework of primary care and kind of what I learned. I learned diabetes, I learned hypertension, I learned all these conditions, I learned mental health. That needs to be integrated, in behavioral health and the mental health, that needs to be integrated into the delivery of primary care. But we have a primary care workforce crisis. If you look at triple-double, there is a simple framework we've highlighted about the primary care crisis, and we need to double primary care spend from 5 cents to 10 cents on the dollar. We need to double the number of people served, starting with health centers, from 10% to 20%. And we need to double the workforce because we have a primary care workforce challenge. 100 million people in our country do not have access to primary care. So we need only 20% of people who graduate. I didn't have a strong peer incentive to become a primary care doc in underserved communities. I'm grateful, my parents supported me and I got the National Health Service score, but I'll tell you, those numbers are going down. So if you need to prevent, detect, screen, and treat mental health, you need a primary care workforce there. So that's known as the triple double. You could Google it on Primary Care for America. The goal is 10, 20, 40. I'll highlight the goal, which I love the Kennedy Foreman, Patrick Kennedy is here, and Rebecca's here. The importance of thinking about measures and treatment. We talk about data, but 90, 90, 90. The importance of us really holding ourselves accountable to improving screening, just like I would worry about breast cancer screening or colorectal cancer screening or cervical cancer screening. Those are frequently highlighted. We need to screen for mental health and substance abuse issues, so the 90% is the target. When you screen someone positive, they need to get evidence-based treatments, that's 90%. And then when they're in treatment and you're targeting recovery, that needs to be 90% as well. So you could Google the Kennedy Forum 90, 90, 90. I think it's a great, simple model for us to think about policy and practice and how we could advance and address these issues at a state level and a national level.
Great, thank you, Drew. That's a perfect segue to the next topic. So I think one of the things that I would like to address is not just counting success by getting money to people, but actually having outcomes of getting people into recovery. And so how can we measure, this is the question, how can we measure our successes? How do we hold each other accountable for that? So what can we do, both short and long term, to do that?
So I mentioned earlier the CCBHC model and the opportunity that it presents for us to have national data. There's a lot of things I covet from the primary care world. One of them is the uniform data system, because I'm like a nerd. But we know by zip code who's getting screened, who's getting treated for what. We don't have any comparable data on the public mental health system. We need that. And forgive me, my two colleagues next to me, we have to stop this states wanting to measure everything a little bit differently. This also goes to plans. You all want basically the same information, but slightly differently. We need to agree on just a couple of common things and commit to doing it the same way.
Great.
We love all states, and every one of them. Working on data and core data sets is something we're interested in as well. And I think the exercise we're doing here is that balance between national standards and how states oversee their system. And that will be a journey we'll be on for quite some time. For us, I think leveraging the recovery community, you mentioned recovery as an example, and I see Patty from Faces and Voices of Recovery here. They have done a nice job to galvanize and to help organize people in recovery, and then go further to say, let's start measuring. Let's press for surveys, federal government, for example, to add in measures on recovery. We should. And I want to recognize the voices of people in recovery where that wasn't necessarily there a lot. I'm a family member. That, though, wasn't known to me until deep into the addiction. And only then I got to understand the real world of recovery and the needs behind people in recovery. And so sharing that is not going to be a one-meeting static exercise, but rather embedding the questions we want into every opportunity possible. So
Great,
thank you.
Great, thank you. And we only have 3 minutes left, so we have a lightning round, a minute apiece for the rest of the questions.
Okay. Thank you. I would just say that one of the things we have to be careful of is states fill out all kinds of data information. And so what we want to do is make sure that it's data that's important and is going to help with evaluating the outcomes. So I think it's basic data. How many people are getting services? How many people are benefiting, are accessing 988? We saw recently that since 988 started 4 years ago, Youth suicide has gone down. Now, is there a way to say there's a direct correlation? Well, previously it was going up, and now we have young people accessing 988. It's one thing that may be very helpful. Looking at how many people are going to jail, how many people are getting stuck in the crazy competency system that we have. What that means is that an individual goes to jail and then they're referred by the judge to evaluate competency. This is often for a very minor charge, trespassing, right? So you've got this waste of money going to evaluating somebody's competency instead of getting that individual help with their mental illness. And by the way, you get stuck in that competency system, it takes months, many months to get out of that, and by that time you've lost your place that you were living in and you've lost your job. Competency system we have right now is ridiculous.
All right, well, I only have a couple seconds. I'm going to say I agree with Chuck.
Thank you, Debbie.
And so do our members. We feel that there are way too many measures, and we really want to go back to focusing on what I said at the beginning, which is, are we helping a person get better? Are we helping a person live the life they want to live? And so that's what, under the leadership of Dr. Caroline Carney, we have a group that's working now on that issue from a plan perspective to really try to focus in on what measures really make a difference, and those are the ones we're going to be focusing on.
I'll just highlight, I would challenge everyone to consider partnering with their local community health center in this endeavor. We like to prioritize the fact that we think we're the employer, provider, and partner of choice. And so you could go find a health center. It's on HRSA's website. And this is where the partnership with HRSA and SAMHSA, these are so important, these partnerships, and all of us as associations. The last thing I'll highlight is stories and statistics. As you think about how policy changes in Washington and in state capitals, the importance of telling your stories, human stories, with patients, with providers, with parts of the system, highlighting the successes as well as the failures and the opportunities for improvement is going to be important. And those statistics are important. I do agree. You measure what you treasure and you treasure what you measure. The opportunity for us to simplify behavioral health measures, and the federally qualified health centers have the UDS. It's a very powerful way for us to track quality, where blood pressure control, diabetes control, there are a few behavioral health measures there, but I think we need to simplify the measurements so payers and providers are aligned, and the payment systems align with that.
Great, thank you. I think that was a fantastic discussion. For decades, y'all's leadership has really, and expertise has helped shape how we support communities around the country, state to state, community to community. We've made great strides, but we have a lot of work to do ahead of us, and I think we're going to try to get going on that right away. Got some exciting stuff that's going to be happening, pretty shortly. So again, I just want to thank y'all for being here and appreciate your support. Good. Excuse me, sorry. For our final panel, we have 5 distinguished guests from 5 different professional associations, medical associations, that we'll hear from, panelists that are going to be joining us. We have Dr. Bobby Mukmala, immediate past president of the American Medical Association, Dr. Robert, I tried to pronounce the name, Piccinini, sorry. Immediate past president of the American Osteopathic Association, Dr. Mark Rappaport, president of the American Psychiatric Association, Dr. Stephen Taylor, president of the American Society of Addiction Medicine, and Dr. Arthur Evans, CEO of the American Psychological Association. Again, I thank you all for bringing your expertise here. It's really exciting to see the representation in the crowd and in the panels from the federal side, the payer side, the association side, the stakeholder side. I mean, this is really kind of plants a flag on recognizing that, I think we're coming together as a nation to address the problems and the mental care situations that we're having. Each of you brings a perspective of clinicians to the folks that are providing care to the patients that we see on a daily basis in our communities. And your organizations represent a spectrum of clinicians working across these settings, from primary care to highly specialized psychiatric and addiction treatment. Each of you as clinicians and as representatives of your respective organizations have been on the front lines working to navigate the myriad challenges that we all have seen facing and struggling with mental illness and addiction. I would like to turn to a couple of questions. I'm going to start. Curious from the AMA and the AOA's perspective, particularly from the vantage of primary care. We know that primary care settings are going to be critical to addressing the addiction and behavioral health treatment gap in the country, and that having more specialists just isn't going to be the answer. How are you working through your members and through your partnerships with organizations like the APAs and ASAM and others to help build capacity among the general medical providers to treat addiction and behavioral health issues and to support long-term recovery? I'll start with you, Dr. Mukamala.
Thanks, Tim. It's great to be here. Already learned so much in panels 1 and 2, which is the beautiful part of being here today, to create a team of organizations, of people, instead of doing this siloed. But as far as what the AMA is doing, to what you asked about helping us get to a better place, mental health-wise and addiction-wise, honestly, the first step of any of this process, I think, is to take a look internally. Right? I think it's reflexive to say, what do we got to do out there? And I think the reality of that has a lot to do with stigma. Right? With a million physicians in this country, you're going to see, I think, a spectrum of recognition, willingness, a sense of responsibility for helping the country with this, right, as the leaders of healthcare and the physician community. And so I think that's something that we focused on, right, to recognize what we think internally, what our reaction is, and perhaps what it should be. And then from there, once we're through that phase of it and have evolved, I think education has a lot to do with it. Like knowing the right thing to do, but not necessarily having the background to be able to do that. For a primary care physician, I can think of a generation ago when I was a medical student, there was some hesitancy for a primary care physician to deal with a mental health issue. Now that's changed. It's taken a big step in the right direction, still a long way to go, but some comfort with the primary care physician treating somebody for simple depression, right? But I think that barrier still exists when it comes to addiction, right? I think we have a longer way to go with that. And this is what the AMA has been working on to be able to learn about the value of buprenorphine, for example, right? In dealing with addiction in a patient in a primary care office, where now you don't need an X waiver to be able to do that, right? I think that's a big step in the right direction. And then finally, I think that the external work that physicians do in their communities, trying to get coverage, right? Dealing with a lot of people that have trouble with insurance, right? And it's one thing to have an issue with a mental health problem or an addiction and even get to the point of being willing to go see your doctor, right? I mean, that itself is a huge barrier. But then to get there and then have to deal with the bureaucracy. I loved hearing that word so much. Not because I love that word, but I love the passion that recognizes that bureaucracy. And then, of course, then there's the long term. What do we do after taking care of somebody's overdose? Right? I mean, that's you guys do an amazing job in the emergency department. But then what, right? That I call it a warm handoff, right? Not a cold handoff, like, okay, you got this appointment, go see this person. That just ain't gonna work, right? We know that. And so the warm handoff, so that when somebody goes from the emergency department to the floor, to be able to be, counseled on, what the role may be of something like buprenorphine. And then the warm handoff to their primary care physician, right? And not even, if that's gonna take 2 weeks because of the shortage that we have of 80 million physicians to 100 not having one, a phone call, right? How are you doing? Your appointment's coming up. That interaction, I think, is something that we are all aware of at the AMA and that we're working on, that continuity of care, that warm handoff.
Great. Thank you, Dr. Mukamala. Dr. Piccinini.
Yes. Thank you. It's really great that the osteopathic profession has been invited here, and the idea of really the focus of whole patient care, which has been in our wheelhouse for over 100 years. For us, it all starts with the person. We know that there's not enough psychiatrists, addiction specialists, or primary care docs around. So what we've really focused on in the osteopathic profession is getting residencies out in those communities, because we know research shows that where a physician trains are more than likely where they're going to practice for the rest of their lives. One of the headwinds of that is, unfortunately, loan repayment, because we see that younger physicians are making decisions about how they're going to be able to pay their loans. So to be able to keep them in those communities, we have to address that issue. Not only that, the American College of Osteopathic Neurologists and Psychiatrists have partnered with osteopathic state and specialty societies for a great number of years to help their members understand behavioral health diagnosis, management, judicial use of medications, and that treatment, along with partnering with core REMS and using not only the better use of opioid medications and judicious use of opioid medications, but really incorporating osteopathic manipulative therapy, which is a certified non-pharmacological treatment for chronic pain. We know that, we've heard some of your panel before saying that, there's not enough primary care, and we fully agree. But the funny thing is, with osteopathic physicians, half of our physicians are in primary care, and over a third of both osteopathic psychiatrists and osteopathic primary care physicians are in rural communities. So we recognize that that was a need, but we started to see that a lot of those physicians wanted advanced certification in addiction medicine. So our specialty college and our specialty board in addiction medicine reopened a clinical pathway to allow osteopathic physicians, and in this case, allopathic or MD physicians, to become certified in addiction medicine. So it's really coming back to the person and reaching them.
Great, thank you. Dr. Rappaport?
Well,
I actually I'm going to change the question a little bit.
Good.
Yeah. I missed the prompt on my script, sorry about that. From the APA, ASAM, and APA perspectives, you guys have been working in the trenches for many years doing this stuff. And how do you see the partnerships that will come out of initiative that we're kind of working on to really focus on providing the best behavioral health care? How do you see that shifting the practice culture, and where do we go from here? Where does the leadership of all y'all's organizations come into this?
well, Tim, first, thanks for the simple question. But before I answer the question, I wanted to bring up one issue that we need to always acknowledge, and that's the importance of therapeutic relationships. Care pathways are important, and educating folks about the best ways of treatment are important. But if you think about it as a clinician, what keeps people coming back, what keeps people doing the hard work they need to do, be it in recovery or be it from the work necessary to be stable with bipolar disorder or schizophrenia, it's the relationship with the clinical teams and the clinicians taking care of them. And so as we develop care pathways, as we talk about the approaches to team-based care, we always need to include that in that discussion. Now that I've done my message, I'll go back to your question. The American Psychiatric Association is fortunate because we've been able to partner with all of the groups at this table and all the groups at the other tables that we've had today. And that's been really important because, as you talked about, there are 5% of the workforce in mental health are psychiatrists. We need to break down silos. We need team-based approaches to care. We need approaches to care that recognize, as was discussed earlier, the unique specialties that we all bring to the table and the unique abilities that we all bring to the table. And you see that in collaborative care. Thank you, Pat Conway. Thank you for those CPT codes that you developed. Thank you for championing collaborative care. Because that is a way that we're going to be able to reach more patients. But another way that we haven't discussed is peer support. Peer support specialists and integrating peer support into what we do. And this is, again, something that the APA is very much supportive of and involved in, is critical success. So it's collaborative care, it's peer support, it's partnering as we do also with the CEO Forum that so many of the leaders here are involved in, that we can work together at what's best for our patients and what's best for their families. And that's really going to be critical to what we do. The APA has a large education component, both educating patients and families, educating peers groups, and that's a very much important part of what we do. And in fact, we do it with the AMA. And we have great partnerships there. Thank you for this opportunity.
Yeah, thank you, Dr. Rappaport. I think that, what you said, something that really resonates with me is something that I really hold as a core belief in that, that addiction is a medical disease, but it's really a spiritual cure. It's a cure of connection. And we can't lose sight of that. And so that's, how do we do that? How do we build that in? It's not, it's not just medicine. Medicines are good sometimes. It's not good, programs and grant, programs, and it's really about connection. And that peer support you hit on is critical. Like, we can't do this without that. It's that connection to family. I mean, that's where the disease lives, is in the darkness of isolation. And so when we shine a light on that, and that's what I think we're doing today, is shining a light on it. And that's, that I get kind of chills when you said that. It kind of reminded me of the core mission of, like, what are we doing? I felt like a little bit sitting on your couch with a session with you. But I appreciate that, because that's what we do, and that's what all of it, anyways. Dr. Taylor.
First of all, thank you for having this event, and it's really an honor for ASAM to be a part of it. For us at ASAM, this initiative is about implementation. We already have the ASAM criteria, which provides us with an evidence-based framework for matching patients with addiction disorders and general mental health disorders with the level of care that meets their needs, and for defining those levels of care. So the challenge now is to have the implementation, to have the care provided according to those standards that's consistent, a consistent standard for the education of healthcare professionals, a consistent standard for the payers and for the coverage that is provided for patients, a consistent standard for the clinical workflows, and a consistent standard for when patients who have these conditions show up and seek help. So we have an opportunity today, because we've got policymakers, we've got healthcare plan executives, we've got clinicians, and we've got community partners all in the same room. And that's a great opportunity. And so now the thing that we have to do is forge the system together that's going to meet the needs of our patients. I've been practicing psychiatry and addiction medicine for over 30 years. And it still is a gut punch to me every time I see patients, and I come across them all the time, even now, who have fallen through the cracks of our system. Cracks that exist because too many psychiatrists, too many other clinicians, or too many systems haven't really caught on to the fact that addiction care needs to be a shared responsibility. And what I think we have the opportunity to do today is to convert the clinical culture You talk about the practice culture in this country, to convert that from a culture in which addiction care is somebody else's job to one in which no matter where you are in the healthcare system, some aspect of addiction care is also your job. Some aspect of mental health care is also your job, whether you're in the pediatric emergency room or you're in the elder care facility or anywhere in between. So I just feel like that's the focus that we need to have. Today, we are here and we're going to be making a pledge. But the reality of it is, just like any pledge, just like any promise, it only has meaning if we live up to that pledge, if we actually keep the promise. And how are we going to know whether we've kept the promise? 3 things we got to find out. Number one, and we got to be asking ourselves this as we move forward. Number one, do more Americans have more easy and rapid access to the high quality care that they need for addiction and for general mental health conditions? Number two, once they've accessed that care, are they able to stay engaged in that high quality care for longer periods of time, long enough to reach the point of recovery? And then number 3, once in recovery, is that recovery being supported adequately with all of the various systems that we know are needed to support someone's recovery? If we can answer those 3 questions in the affirmative, then we will have lived up to this pledge, and this pledge will have meaning. If not, we've still got work to do.
Yeah, thank you. Thank you. Dr. Dr. Evans?
Yes, first of all, again, thank you for putting this together. I think it's great that all of us are in the same room at the same time talking about these issues. I think from our perspective, the American Psychological Association, we believe that we need to look at these issues from the perspective of this is an incredible opportunity to rethink, reimagine how we approach healthcare. And I think one of the themes that we've heard so far today is this idea that we have to do it together. We have to have multidisciplinary teams. There is no one profession that can deal with the complexity of behavioral health conditions. And that means that every profession has to operate at the highest level of their license. And I'm glad that there's a discussion about bureaucracy and regulations often that limit people, and we really need to look at that and make sure that people are operating at the highest level of their license. There are a few principles that I think are important as I've listened to this conversation. One of them is flexibility. We've talked a lot about integrated healthcare. The reality is that if you look around the country, even though we've made a lot of progress on integrated care, most of the country, it's just not happening. And we have to recognize that different parts of the country have different needs. If you're in frontier America or you're in rural America, a lot of the things that we take for granted in some of our urban areas just aren't there. And so if we want integrated care in those areas, we're going to have to be more flexible. And so we need to be thinking much more about principles and not being stuck on particular models. So flexibility is one of the things that I think is really important. Another issue, and I'm here as a provider, I guess, or representing providers, but most of my career I was a public payer. And the one thing that I know is that if we really want to change the system, we have to have payment models that get us what we want. We pay for process, that's just the reality. We don't pay for outcomes for the most part. But when we do pay for outcomes, we get really great results. When I was a payer, we talked to our inpatient providers ad nauseum about continuity of care and making sure that people had a good referral when they left treatment. What we heard over and over again was, well, we really can't do anything once people leave treatment. We implemented pay for performance. One of the providers that was at the bottom of the distribution the first year that we did it didn't get any payment, saw other providers, inpatient facilities get very significant payments. In 1 year, they were at the top of the distribution. And all we did was change how we paid. And so if we want different outcomes, we're going to have to align our payment systems around the outcomes that we want. And that means not just looking at those kinds of metrics, but really looking at how do we set up systems so that providers are being paid for the entire course of treatment. Believe very strongly that we ought to be looking at accountable care organizations and other payment models that really focus on all of the needs that people have. The last thing that I would say is that we have a great opportunity to incorporate technology. Our organization passed a policy around population health, really emphasizing the fact that we can no longer simply treat people after they're in crisis. And you look at most people who access treatment, they're accessing treatment after they're in crisis. We have to get upstream, and that means that we have to look at people and be willing to intervene with people before they have a diagnosis. Because a lot of times when we wait till they have a diagnosis, it's a problem. I think most people agree that we ought to be taking more of a population behavioral health approach. We have to have then the payment models that do that, but we also have to use the technologies that allow us to really do population health. The problem that we have is that we don't have enough behavioral health providers. But with AI technology, we do have an opportunity to do some of the things that people need. I'm not a believer that we can do psychotherapeutic interventions yet, but there are a lot of things that people who have behavioral health conditions need. A lot of those things can be done by technology, and we ought to be looking at how we can use technology to do some of those things.
Great, thanks. That kind of raised a point that I wanted to highlight, and that's, when we talk about prevention, I think our, Western-based medicine, our medicine is based on treatment, so we're really good at treating things. But the problem with that is when we focus on that is that, it's like waiting, we have really good burn surgeons. So, so we focus on that, but maybe we should be focusing on people not getting burned. It's the same kind of thing, where I think that the focus, we need to still focus on treatment. We need to provide the best possible care to the patients that get there. I equate it to almost like a cancer. So you've got someone, you don't want to wait till stage 4 cancer or stage 3 cancer. You want to catch them when they're in stage 1, when you can do minimal intervention, and then they're healed and they're cured. And that's, for me, that's really exciting. One of the reasons that I was willing to, like I said, leave my previous life, sell our house, move out here to do this, and that's to have a change in the kind of the core culture, and going back to the basic principles of human connection. Eat with your family, play with your friends, eat healthy food. Food is medicine. I don't know how many times in the ED I saw people come in who may have high blood pressure and diabetes and things, and they just would want a pill to get. And I said, well, you gotta lose some weight and you gotta exercise. And I would ask them, they come with anxiety, and I'd say, well, what about, can you have like a spiritual connection? Do you have, that kind of thing? Are you connected with your family? Like those things, like your grandma would say, duh, you gotta eat right and you gotta exercise. Those principles, common sense things. I think we can be so much of what we can do. And that's a cultural shift, but there's so much that we can do with that respect that can really kind of get to the root, and that's where we need to kind of like reboot how we view health in the country. So,
yeah, for sure, Tim. You bring up something that's on my mind a lot, and I give in a lot of my speeches. I'm traveling as AMA president, and that's what we call lifestyle medicine, right? And it's simple stuff, 7 hours of sleep, dietary stuff, but one of them is social interaction. Right? And when I think about it, as a head and neck surgeon, those patients that have head and neck cancer, whatever stage it is, they do better when they have good mental health. Their survival is better. Right? And so for us to recognize the intersection, it's not two separate pillars, like we're going to do physical health, but we're also going to now focus on mental health. One has an immediate impact on the other. And so I think you bring up a great point that to ignore that and expect better statistics about the health in our country is foolish, and so that's why this is so important.
And that, also that another area I wanted to focus on was the mind-body connection. So there's so much that's tied between, what you're thinking and how your body's working, and that simple shift of doing the things that connect you to your family, connect you to your spirituality. Those things are I'd say are better medicine than a lot of pills are, and that's that kind of the drive that I have is pill culture to purpose culture, chemical coping to human connection. Like that's to me that's what it's about, and that's just those core core principles.
In the osteopathic profession, our main tenet is body, mind, and spirit, and integrating all three. But I'd like to take us down a little bit different track too for just a second, because I think as being a psychiatrist, the first psychiatrist in the osteopathic profession to reach this level, I think it's important that we don't forget, we've been talking a lot about our populations, but we can't forget about the mental health of our providers themselves and the risk of burnout that we all are facing for the burdens that are put on us. But if we're not willing to see our own mental health issues, it makes it much harder to accept and deal with the mental health of our patients sometimes. So I don't want to lose sight of that aspect of when we look at how we go forth in this pledge, to really truly incorporate not just the whole person outside the white coat, but the whole person inside the white coat or in the treatment room.
Yeah, that's good.
Well, what you're talking about there really rings true to me, since my lab for the last 40 years has studied the interaction between the brain and the immune system. And I like to say, the mind and the body are connected. That's why God made the neck. But what we also know is that there are many ways of intervening. Our psychotherapies and a lot of our traditional approaches are top-down approaches, but there also are possibilities for bottom-up approaches to modulating the brain. There's good data, for example, that shows you can treat GAD with massage. There's data showing you can treat cancer-related fatigue again with massage. There are clear data showing that exercise is important, not just for physical health, but also for mental health. And we see that in anxiety, we see it in depression. So there clearly are these ties that need to be reinforced in any care pathway we deal with. But in doing so, we also need, you talked about the importance of outcomes, others did, and they also talked about the importance of having an EMR that deals with this. One of the problems we face is that most of our EMRs aren't well set up for measuring mental health or psychiatric outcomes. And so we would need to, as part of this effort, change that. We would also need to change the payment model, because right now, if you have a depression that's well treated or bipolar disorder that's well treated, if you're in remission, it's hard to get reimbursed for the same type of follow-up visit that you would have if you were treating somebody with diabetes or treating someone with hypertension, where of course you would check and see how they were doing and check and see if the medicines are correct. But that's hard to get paid for in behavioral health. So if we're going to fix the pathways, that's part of what we have to fix as well. Thanks.
Great, thanks. Dr. Taylor?
So I'm going to add to what Dr. Rappaport just said. That's also true for long-term recovery from addiction. We at ASAM applaud the fact that this administration and everyone here recognizes that addiction is a chronic medical condition that can be treated and controlled, but typically not cured, and therefore recurrences can occur, right? But what that means is when we get someone into long-term recovery, that recovery needs to be supported. And by the same token as Dr. Rappaport was talking about someone with bipolar disorder who's in remission, or someone with major depressive disorder that's in remission, same is true for someone with opioid use disorder or with cocaine use disorder who's in remission. That recovery needs to be supported, so that we need to have coverage from our premier coverage institution that provides insurance coverage for people on an ongoing basis, because it is a chronic medical condition, and I think that's something that's really important. I also wanted to pivot to the whole discussion about mind and body. One of the things that I have enjoyed working with my colleagues in ASAM and throughout ASAM is that we're not all psychiatrists. I happen to be a psychiatrist, but the president-elect of ASAM is a medical toxicologist. And we have numerous members who are primary care physicians, who are pediatricians, who are OBGYNs. Why is that important? Because we want to be able to reach people at whatever point in the healthcare system that they might present with a substance use disorder, and we feel it's important for people to be able to get care from someone who's knowledgeable about addiction and about general mental health concerns, regardless of their specialty. Again, we want whatever point that you happen to occupy in our healthcare system, it is, at least in part, at least to some degree, your job to help people who have a mental health condition or an addiction disorder, at least to some degree, to help them with that condition. And I think that underscores the fact that, yes, we are all in different specialties and everything is so siloed. The way we bring it together is by all of us owning this, because we understand that there is a connection, an inextricable connection between mind and body, between mental health and physical health. In fact, mental health is health.
That's great. I want to bring, before I get to you, Dr. Evans, I want to bring one point up. I think one of the things that I look at is the way that we treat addiction, like it's a real disease, medical disease, chronic medical disease, is the same way that we would treat diabetes. So if a diabetic came to us and had been off their insulin and had been eating cookies and came in with a blood sugar of 650, and in the ER this happened, multiple times, the same patient over and over, I never got to the point where I said, I just gave up. I'm like, that's just not going to work for them. I'm not going to, they're insufferable. It's just a homeless drug addict, and there's, it's never about that. I think that's, for me, that, I always felt like, there but for the grace of God go I. So, and seeing the humanity in all of us and in our patients, and building the systems that give them the opportunity to get the care. We would never say, you got 7 episodes of treatment, it didn't work. You're shit out of luck, like good luck kind of thing. And so, and the other thing I wanted to bring up, I think too, is I learned this in recovery, 29 years ago when I went into treatment, is that, there's not a cure, it's in remission. And so while I'm doing this, while I'm in sobriety, while I'm working my program, my disease is doing push-ups, and it's waiting for me to relapse, and it's waiting, and it's going to come back stronger than when I stopped 29 years ago. And that to me is like, that's the reason that we have to build these systems, and then figure ways out that we can continue the care to treat it like every other chronic disease. But, yeah, Dr. Evans.
Yeah, I want to go back to the point you were making about prevention, which I think is so important. I've been in the field for over 30 years, and I think it's probably one of the most important things we can do for behavioral health. So much of our resources, 90%, are on the back end of issues. And one of the things that Dr. Oz said, and then when he's talking about youth and getting screened in schools, and Brian Herpern when he was talking about criminal justice, the reality is that people who have behavioral health conditions, they show up everywhere. And they don't come to us as providers often. They show up in hospital emergency departments, they show up in criminal justice, they show up in the schools, they show up in child welfare. And one of the things we have to do is we have to embed behavioral health expertise in those settings. Not only putting people, but I think one of the things we've even heard on this panel, we have to empower other people to be able to recognize these conditions and know how to intervene. Most people don't. And so people languish. And so I think we have to take a more comprehensive approach in the way we look at it. How do we make sure that we are putting services and people in the places where people actually go, as opposed to requiring people to come to us? We know for addictions, only 20% of people are going to access treatment, and for mental health, it's less than half. And if you're talking about certain groups, it's even a lot smaller. So we have to be a lot more creative about how we're going about addressing these issues, making sure that we're meeting people where they're at, and that we have payment models that are flexible enough to make sure that we're supporting people in that way. Last thing that I would say is that and I think we've heard it here again, at the end of the day, we can be very good technicians in what we do, but at the end of the day, it is the personal relationship that people have that really helps. And I've been in programs so often where you ask people, what really helped you to get through treatment? I've never heard anyone say, Doc, it was the paradoxical intervention you did on the 3rd session. They never say that. What they're most likely to say is, well, you call me sir. You call me mister. It's those little things that connect. And I think as we're talking about technology, we're talking about protocols, that we have to make sure that we keep that part into the way we treat people, because that's really what helps people to get better.
I think what you highlight is thinking outside the box. So, the system is the way it is now, and it's the way it's come together. I think everyone, it's not because people aren't trying to do the right thing, but how can we reimagine the system to be what the system could be? What's the ultimate expression of what the mental health system could be? What's the ultimate expression of what SAMHSA could be, or HHS? And I think then try to move towards that goal rather than, we still want to do the best that we can with what we have, but then also an aspirational thing of what can we do, a part of that. So I'm going to throw that back at you, Bobby, is, what's next? I mean, how do we take this kind of moment that we have and the opportunity that we have and go forward?
Yeah, I think that's the critical question. So how do we improve the mental health of our country and deal with those people that are most in need? I think just the very basics, like workforce, right? We need to have a workforce that is big enough to actually solve this problem, as opposed to just drowning/treading water. Right? I think that's where we are now. We need to have that kind of robust workforce. Part of it is when we have that workforce, like we talked about many times, I think it's come up in every panel, the bureaucracy of trying to do the right thing, right? Things like prior authorization for doing X that I know my patient needs, my patient wants, but then all of a sudden we have this barrier. And then, the compensation for doing that work. It shouldn't rely on our morality. That's there. Right? But then physicians suffer what we call moral injury, where we know the right thing to do, but the compensation for doing it and the hassle factor makes it difficult to do. That injures us inside and then leads to our own issues with our own mental health. And that's why I think this is an amazing moment. There's lots that I, as a physician, that we as the AMA disagree with an insurance company on, right? Our mission and insurance company's mission are oftentimes, when you read them, they sound good, but the reality is it's sometimes difficult. But this is a moment for all of us to sort of have the same north on the compass, right? To agree that, yeah, these are our mission statements, but this is our mission, right? To improve the mental health of our country, to get over the consequences of addiction, where we lost 110,000 people not long ago. Now it's down to 70,000 from overdose. But if that's our mission collectively, then we will move together in that. And again, like somebody said earlier, it's not just a signature, right? It's taking this forward and looking at how we think. And every time this comes up, not looking at the mini north on the compass, but the north on the compass to guide us. And that's what I'm excited about.
Awesome. Yeah, and that's exactly what we wanted this pledge event to be about.
With everything that's been said here, I think I agree totally with it. I think one of the other things we need to do as a society is primarily destigmatize what getting mental health treatment means. Too many times when we see a bad occurrence, social media goes down the pathway of they must have been crazy or there must have been a mental health issue. And oftentimes there is nowhere near that. Sometimes there is, but sometimes there isn't. But it sets up a resistance for patients, providers, to get the treatment that they need. So I think some of the barriers are, legislative, the bureaucracy, but also toning down the social media negativity that we see in getting mental health treatment. It should be something that is applauded and honored, as opposed to something that is spoken in the corners or in a dark room.
Yeah, that's one of the things I wanted to also with working at SAMHSA is to focus on celebrating recovery from addiction, from mental health, and from all chronic diseases. And that's, I think, the positive message, and that's what's really exciting to me is that's the country is divided, but I think we can all unite on like we should be better to each other. We want people to be healthy and happy and successful. I think 95% of us have those ideals, and so I think that's really it's exciting to be able to unite around that core drive.
Yeah, I absolutely agree about the need to decrease the ignorance and shame and guilt and prejudice associated with mental health and substance use disorders. And that's why campaigns like Love Your Mind that the Ad Council's done is so important, where there were 5.2 billion impressions the first year. I think the point that Arthur, you were bringing up again, and Tim, you started with, about prevention is critical. The schools are a place for doing this. It's not just a place to assess the child, but rather to intervene with the family as well, and create a community that is pro-mental health. Data from Nina DeLacy has shown that families with kids before the age of 5 can identify kids that are at risk and at risk of developing externalizing and internalizing disorders. We need to intervene early with families in terms of education, in terms of breaking down stigma and saying, hey, we're not criticizing you as a parent. What we're doing is working together with you so your child doesn't get anxious and depressed. So preemptive interventions or preventative interventions are important. Preemptive interventions are great. Ed Craig has developed a program that's in Iceland, it's in Portugal, it's in Sweden, it's in Greece, where they can identify kids at age 10 and 12 that are at risk of developing a depressive disorder, and with a 3-month intervention, it's a therapy intervention for 3 months, they decrease the risk of converting into a mood disorder by a factor of 8. The other thing that's very important that we talked about is it's not just looking at symptoms, it's looking at quality of life and functioning. And it's ensuring that if we're going to look at outcomes and results, if we're looking at value, that's part of the value as well. Thanks.
Thank you.
So I've been sitting here and listening to my fellow panelists here, and I heard my friend and colleague, Dr. McCamala here from the AMA, quote the statistic that so many of us have focused on and have been aware of for a long time. The fact that we went from a high, an unconscionable high of 110,000 overdose deaths in this country to where over the last couple of years there's been an improvement to 70,000 overdose deaths in this country. And I think everybody in this room can agree that 70,000 overdose deaths in this country is still absolutely unacceptable. And I think so when we talk about where we go from here and what do we do about stigma, I think there are some things that ASAM's been prioritizing that are attempts to really operationalize destigmatization of addiction care. For example, we have a medicine that we know can cut down the death rates from overdoses from opioid use disorder by at least 50%, and that's methadone. And so we need to, one of the things that we're going to be working on is trying to make sure that people have access to that medication and any other medication that is evidence-based, that has the ability to help people with addiction disorders to be able to live longer, to stay in recovery longer, and therefore get those recovery outcomes that we talked about earlier. So that's one of the things we're going to work on. We're also going to work on the fact that being a senior who has an addiction disorder should not be something that works against you. So Medicare needs to cover the Recovery Act for seniors so that a senior can get residential addiction care that is evidence-based, that also takes care of the co-occurring mental health conditions that they have. We shouldn't have the fact that you're a senior citizen in this country mean that your Medicare doesn't cover the treatment that you need at all levels of the care continuum. And then finally, the last thing that we really want to make sure that we emphasize is that we have to have people who can get access to addiction care, quality addiction care, regardless of your zip code, regardless of your ability to nimbly negotiate fragmented care systems, and regardless of what kind of insurance coverage you have. People need to be able to get access to high quality care without any of those factors being determinative of their access.
You know, what I'm hopeful about is I think we're at a really critical point where we really are starting to rethink how we approach our work. We know what helps people to stay psychologically healthy. We know that. We have years of research of that. We know how important social support is. We know how important behavioral activation is. We know these things. The problem is we've never used them in a systematic way. You know, Mark's point about early intervention. You know, if you're a family member and you have someone in your family who has either an addiction or a mental health, a serious mental illness, you know when they're about to go into crisis. But if they don't have a diagnosis, they're not going to get treatment. We know that that's a problem, and so we really need to question some of the fundamental ways that our systems are structured that keeps people from getting the help that they need when they need it. And we ought to be using the science that we have available to address those things. So I'm hopeful that what we can do going forward is to really rethink. One thing is really sure. If we do the same things, we will absolutely get the same results. And if we want to get different results, we're going to have to radically change how we're coming at healthcare. And so I'm very excited about that, and I hope that we can use technology, because for the first time, I think, certainly in my career, you can see a possibility where through the use of technology, we can actually reach people, not to replace us, but to enhance us, to enhance our ability to reach people. And I really hope we can really embrace that, because that gives us an opportunity to reach people that we've not reached before, to reduce suffering, and to ultimately improve the overall health of people.
That's great. You guys, I really thank you so much for coming out here. Okay, now I'm thrilled to say we have a very special guest. It's my honor to introduce our next speaker, HHS Secretary Robert F. Kennedy Jr. Secretary Kennedy is leading a nationwide movement to reshape how America thinks about and addresses addiction, as well as all chronic diseases. His commitment to making recovery possible for millions of Americans who are struggling is unmatched, and we are pleased he can join us today, and I'm honored to serve with him. In a minute. But so honestly, I just want to circle back to appreciating everyone that came here and the time that you took in the short amount of time getting out here, taking time from your schedules. This is very, I think, important for us to do this and to kind of plant this flag. And I know that for many of us, probably most of us in the room, this is not just a job, but it's a passion. And I pinch myself every day that I get to be able to do this and to make this kind of a contribution. And I just can't wait to get to work with all of you. And I think we can really make a big difference in the country. I could tell some ER stories if y'all like. So what we'll do when the secretary speaks, we'll have the speakers come back up and we'll sign the pledge, and then we'll have members, and then After that, the secretary needs to leave. He's got to get to another event, and then we can let everyone in the audience sign the pledge as well. There's going to be a QR code that comes up on the screen, and we can have people sign with their associations, and people at home online can sign as well. If we had a drum roll, we could. Here he is, Secretary Kennedy.
Hey, everybody, I'm very sorry to keep you waiting. It is. Every day is a crazy day here, but this day was really crazy. And I'm very, very excited to be here. This is an area that interests me tremendously. We're seeing for many, many years, mental health and substance use disorders have been essentially playing on the fringes where they're not really in the house of medicine, and they've been judged by different standards and not properly compensated. That parity was absent. It's now becoming more and more clear to all of us that those two areas are inseparable. We have something like 80% of the SSRI prescriptions being written by general practitioners in this country. And there's so many now. We're understanding more and more the links between mental health disorders and physical disorders, and the link between gut health and mental health illness, and all of these other intertwined things. We have to start treating this as a single area. And it's our position that we'd like to fight as hard as that we can to make sure that those kind of treatments that have been traditionally for mental health are treated with parity in our system, but at the same time, the people who are administering those kind of treatments have to step up their game, because we all have to, we need standards where we can measure success. We need outcome-based standards. If you go into a hospital with pneumonia or diabetes, there are standards of care that people know about, and they're evidence-tested, and and we know what works, and we don't know what works, and we apply those standards broadly across the entire universe of healthcare. We don't have that in mental health, and we don't have that in substance use disorders. We have a lot of silos, and there's no real place where there's a meeting of the minds on what works and what doesn't work. And we want to devote resources to making sure that we can develop those, but we need help from your entire community. And part of the pledge that we're asking everybody to take today is a pledge to step up that game so that we're all playing by standards that are measurable, that are outcome-oriented, and that the public will trust and the taxpayer will trust when it comes time to reimburse these. Well, I want to thank you all for being here. Thank you for your commitment to this. And am I introducing somebody?
No, we're gonna do a picture next.
Okay, now we're gonna do a picture. I'm really grateful to be here. Thank you.
If you could have the panelists come up on stage, please. out of your schedules. This is, I think, a historic day. I don't think anything like this has ever been done at HHS or within the government, and I think this is the start of something that could be really exciting and transformational. And please, this is going to close the ceremony, and we have the boards up on the side if you'd like to sign the pledge. Also, there's going to be a QR code up that we can have your associations sign. You can sign those as a permanent piece. So again, thank you so much, and I appreciate all the guests and Secretary. And again, this is really exciting, and look forward to working with everyone. Thank you.